distinguished participants. Yes, today we'll be having a hybrid format. The time and circumstances dictate new conditions for us. I welcome the participants who are present here in this room, the ones who have joined us via Zoom platform. We have participants who are watching us via YouTube as well. Allow me to tell you a bit about the project which the Belarusian Association of Social Workers has been implementing since last year in partnership with our colleagues from the medical healthcare system and the social service system. The chief idea why we have come together is the development of the community-based support system for people with mental illness and families affected with mental illnesses. In fact, the association itself has been working on mental health issues for many years. We started as early as in 1996 from such educational conferences and capacity building seminars for our colleagues in Belarus to share best international practices and experience which are interesting and useful for our target group. And one of the models that the Association of Social Workers has been working since 2011 is the well-known international model called clubhouse. This is a form of a rehab society which the association in the course of more than a decade has been developing in Belarus. Now we have 4 clubhouses in place, and this model will be overviewed more in detail by our foreign colleagues about their efficiency, how it works in other countries. I'm not going to go any further on that, but the principal idea of this model is that it has been working on the principle of a local community, and it is based on such a concept which is called recovery concept. When a person quite likely might not be cured from a disease, for instance, but this person can be restored to a certain level of development, and in that process, this person requires assistance, and we as professionals can provide such assistance. Ever since last year, we started together with our colleagues a large project that we called Social Dialogue. Why dialogue? Because we speak to each other, we advise each other and consult each other how to make it more systematic. And within this project, I would like to share with you resources which might be useful for our practitioners who have been working on mental health issues, who provide their assistance, who work in the educational system for people with mental health problems. And one of the resources I wanted to share with you, under our project, we developed a so-called service map in Belarus. The service is available to people with mental illnesses and members of their families. You can look at this service map. We've been working for a number of months to collect or put together all the information about the available services. If your organization is providing such services but you're not on the map, please pitch in for this partnership process for the people with the history of mental illness and join us with that. Please share with us your services and tell about your services to our people with a history of mental illness. Tell us that based on your organization, you're also providing such services. You can freely fill in a questionnaire for your organization on our webpage, and after the fill-in process, our map will be updated automatically. The second resource we prepared, again, a great opportunity for us to exchange experience and talk to each other and share practices. We have done a professional society resource. A number of our specialists and experts have already shared their cards that they filled in. What is it all about? There is a possibility to tell about yourself, about your interests and professional priorities in the mental health issues. Also share some experience and announce that you're, for instance, looking for partners in the field of mental health. Such professional resource databases work very well in many countries of the world, and they help those professionals who are looking for the opportunity to find each other and develop joint projects. A third resource that we have added, it has been working already, and a number of initiatives have been added there. You can tell about your initiatives that have been already operating in the field of mental health, the services that you provide, the projects that you implement in the interests of the people themselves, people with mental illness history, and also for the families with mental health issues. And in our resource center webpage, we have a separate tab called Initiatives and Projects. There you can also fill in the questionnaire and share with everyone what kind of work you do, what you do in this field. What else have we done in the course of this year and plan to continue this work? On the same Info Center resource, we organize webinars. We invite experts on different subject matters, but the overarching subject for us is the mental health and providing support to mental patients, and mostly those who are capacity building webinars for specialists, but they can be equally useful for all. These webinars are now available in recording for all. You can visit them and view them. And also there I advise you look at this resource. Last year we had a very interesting event called the Mental Health Week, and within that week we were joined by our great renowned colleagues from other countries who shared their experience in how to organize and support different categories of people in the field of mental health, where they discussed and things how to assist, for instance, elderly people. There was a separate matter for discussion how to combat burnout of specialists working in the mental hospitals, so regular clinics, and these videos are available for all. And one of such signature events organized this year in a number of towns, we organized the so-called conferences on open space technologies. The principal idea of this, why we initiated this, the main idea was to unite on this platform, on the free platform, an open one where everyone can announce the subject which is important for them, to unite professionals working on mental health and other people who are maybe affected by this matter, the members of the family, friends, and everything. Other organizations who are so far not related to mental health issues but are interested on working on inclusion issues, for instance. It also includes cultural institutions and educational institutions and organizations. And we have attempted to seek for particular towns and cities where such platforms were opened, what is important for them in mental health and how to support people and what can be done in that department. Owing to these initiatives, and because they were such unstandard format of a conference, when we had many reports and speeches made there, people could learn from interesting ideas, and some of the towns gave birth to interesting initiatives and projects directed at the support of the family members and other inclusive practices and ideas through the inclusion of people with mental illness. If you find it interesting to learn about these materials, what was recognized as a result of this open space technology, you can get in touch with our association, and we will gladly share this information with you. We'll gladly share the information about initiatives which are ongoing based on the results of this project. In fact, this is what I wanted to tell you about this initiative. Now I invite all the people who are interested, colleagues, please join us, and also colleagues who are here now and colleagues who have joined us via Zoom platform if you are not included yet. But if you find this subject close to your heart and you find it interesting to cooperate with us, please get in touch. You can write to me or call me, and we will connect you, of course, to this project. This is not the only project which is being implemented by our organization in the mental health issue. All other projects are free to you to join and to learn about on the Belarusian Association of Social Workers webpage, where you can read about Clubhouse and how it works. Thank you very much for your attention. Now I would like to give the floor to my colleague, who unfortunately couldn't join us personally, but she has joined us via Zoom platform. Her name is NATALIA MILKOTA. She is head of the Center for Research of the Field of Social Protection and the Scientific Research Institute of Labor and of the Ministry of Labor and Social Protection. She will tell us about the social support and services available to people with a mental illness history and the families affected with mental illness. Natalia, over to you now. Hello, everyone. And I'm going to try to launch my presentation. Alena, please tell me, are you going to launch it or can I do it via Zoom platform? You can do it yourself, Natalia. Okay. Can you see my presentation? Yes, we can see everything is operational. Perfect. Hello once again. I represent here the scientific institution under the Ministry of Labor and Social Protection of Belarus. And today I will be speaking about the social support for families. But mostly I will be talking about social services and social work because this is the principal field of my activities and my interests. To make sure that we make it more accessible for us and our foreign colleagues to remind ourselves also when we speak about social support, we imply on the one hand in Belarus quite a significant part of that social field or rather social service is performed by the state-owned sector. And in that regard, it is important to understand that we have special institutions, also mental institutions, which is obvious. And later on, we are going to speak whether there are any changes observed in the past few years. And there are also territorial centers of social service. And such centers, we have 146 of them. The main social standard for them is that in each district, such a territorial center, which provides social services to different categories of citizens who require them. Also, these centers employ social workers who can go door to door and visit mental patients, and there are also daycare centers, which are focused, first of all, on people with disabilities and the elderly. So in terms of basic infrastructure, that's what we have for you to understand. What kind of services they provide, I'm going to speak about it later on. But now, on the other hand, I would like to say that there are also NGOs, like the NGO Belarusian Association of Social Workers. Alena just told us about the new approach called Clubhouse and other organizations that I personally know and I'm personally in touch with and had the honor to cooperate with, who run different projects one way or another focused on people with mental illness. On the one hand, I can say that indeed, from the point of view of, say, establishment of such a work in a community, it is the NGOs which are much more fruitful and productive, I believe, with all due respect to the state-run system, which is supposed to ensure and protect basic guarantees and services that any person or his or her family requires. But in terms of other variegated forms of work, flexible, human-oriented, oriented towards or focused on their individual needs and their personal histories, I continue to be completely confident that it is the place and role for NGOs who might be more effective here. Unfortunately, because of the complexity of the subject matter itself and the complexity of working with such people and some of the circumstances related to different mechanisms of control and support of NGOs, in fact, this prevents me from saying that this segment, or rather public non-governmental sector is, I wouldn't say that non-governmental sector is too big at the moment. That is why such projects as the long-running projects in different cities like the Clubhouse projects are very valuable for us. Speaking about the state-run system, it goes without saying that all the services provided through them are regulated by legislation. And here we have the principal law on social protection, where we are talking mostly about the existence of a number of circumstances by which a person or persons can be recognized as the ones who require social service, which gives us the ground to provide such social services. One of such conditions would be, or circumstances could be, the presence of a disabled child in the family, or some limitations of a person to do self-service or individually move around. At first look, we see that there is no direct indication about mental illnesses among adults, and these things are regulated by the law, which at the moment is being redrafted, or rather amended, the law on the rights of the people with disabilities. It is now in the resubmission limbo, and also we have a law on the psychiatric assistance, and whatever is related to technological services is also part of that. One positive thing, though, is that this list is not closed, rather it's an open-ended list. We cannot say that social services can be provided only to these categories of citizens who are listed here. No, there is also a separate mentioning in the law. There can be other circumstances recognized as such by organizations or NGOs. Basically, any organization, even an NGO who start their operations, can decide on their own category or target group of people, no matter how they look at it, and develop such services and consider that people on the receiving end require such services based on their own observations and results of some studies or research. Thus, what kind of services are provided by such organizations? There is a whole list of such services which is being regulated, and services can be very diverse. And another thing I wanted to underline is that on the right side of the slide, if I look from me, on the one hand, local services can introduce other types of services and specify the groups of citizens who are entitled to them, even at the level of local governments. In other words, according to our legislation, they have some freedom of choice when such services can be developed, augmented, and disseminated among broader groups of citizens. And the same is equally true about the entrepreneurs or NGOs. They can decide on the types and list of services they are eager to provide. So now, speaking about the categories of people with mental illnesses and mental conditions. First of all, the services, if I make a throughput overview, they're more focused on these people, first of all, to make sure that people would receive such support from the point of view of development of social communicative skills and their restoration at a certain stage, because we should understand that in Belarus, at least, such thing that internally we imply also some mental things is of great importance, and often, practically speaking, it is of decisive matter for an organization whether they're going to work with all people with mental conditions, or they're simply focused on people with cognitive conditions, like people with dementia or young disabled people who have certain form of cognitive disorders. Now, speaking about, well, in the same manner, the services of assistance who are there to help, first of all, people with cognitive disorders who would be enabled to live alone or live independently. Also services for people staying in a daycare center, what I spoke about earlier in the beginning. They are, first of all, designed to build up the skill set of people so that they could be better integrated. Speaking about the position of the relatives or family members, it turns out that all these services are more like to ensure the supervision over these people. From the point of view of families affected with mental illnesses, such services are provided to a greater extent, are mostly designed to make sure that a person, a member of the family, like a parent, could be alleviated or relieved from such caretaking responsibilities. So this daycare supervision services recently introduced, specifically because before that there was a sitters, nurse services provided to people with mobility disorders, but the daycare center services are first of all focusing on people with the behavioral control. This is one of our indications for the people who are in need. These are functional disorders based on certain conditions, and the impossibility of behavioral control would be true about people with cognitive disorders. And this daycare centers are provided both in-house or in a specially designed center. The main idea of this service, when it was introduced, was to ensure some safety supervision over the person when the principal member of the family or parent could do his or her career or rest a bit. First of all, here we had in our mind the idea of an elderly person with dementia or young adult with intellectual disorders, and the daycare center stays in some towns or cities. There are such institutions employing a staff of specialists, which is who are prepared and knowledgeable on how to work with mental patients, so that there is no need to send their family members with mental conditions to institutions, but instead they could send their family members for, say, a few days or 1 month. There can be short-term stays, like 1 month stay, but it's sometimes it can be done over the clock, around the clock, but it can be done for a month or a few weeks. Speaking about the services provided to family members performing different function, not just simply to relieve them from these responsibilities, but to support them. Here, at this moment in time, these services include awareness raising, information about the rights that such citizens are eligible to, about the social support and social work, training how to do proper care. This is a recently introduced service. Again, it is mostly designed for family members who have a family member with mental illness and having problem to do self-care, or more limited in self-assistance. And there is a more integrated service called social patronage. Social patronage is designed to look at how critical the situation in family is and develop a plan with a list of services specifically designed for all family members. In terms of the social patronage and how to use it, I think we need to develop this idea further. And there is another separate mechanism, which not within social work, but very close to that. We are working closely now to integrate it into social work to support non-formal care. This is a benefit or a special pay for people, or bonus to pay to family members to support elderly people, who are to support people who are not employees of social services, including relatives who quit their day job to take care of their ill family member with such a need. But again, mostly we're talking about caretaking here, and more often than not, we have some strict restrictions here related to the age and the high level of functional disabilities. Speaking about good things, the trends which I, as a representative of scientific community, has been observing in this development of the social work system in the past 5-year period is that internally the system now realizes the need for deinstitutionalization. Especially it is true about children with disabilities, young adults with disabilities, and social work in general. Whereas earlier, significant resources were invested into the development of stationary network of orphanages and institutions. Now more attention is paid to keep a person at home, and this is a new law on the rights of people with disabilities and social integration, is targeting mostly the situation that a person with disability should stay in more comfortable conditions, which is fully in line with the norms of the Convention on the Rights of People with Disabilities. And similarly, the strategy of active aging about the elderly people similarly strengthens or reinforces such principles of deinstitutionalization and to bring people closer to where they used to live. And the second aspect, which is important for people with disabilities, this is the trend of counterindications. There were a lot of complaints about the social work in the past when the system shows its unreadiness to work with people, how to control their behavior. Now, on this slide, I've demonstrated that for a in-house service, there is only one restriction on control, FK4, as we call it. Here we are talking about people who, as a rule, are in an acute phase or active manifestations of their disease and are unlikely to lead a normal life under such condition, or in group work or focus groups where there are some restrictions on the different categories of citizens with psychiatric assistance. Direction-wise, there are two directions which are intensively developing at the moment. They include services for the elderly with dementia and services on caretaking for the elderly and for training of the family members how to do that. And another is the rehabilitation system. Interestingly now, the new law on rehabilitation provides an additional message on a 3-level social rehabilitation system, where the basic level is strengthened behind these territorial centers, administrative territorial units located also in the social stations, which must be customized to better meet the needs of people. So they might be located in the close proximity, and also considering the real resources and capacities of local communities, so that the territorial center could also coordinate the work, and not only in terms of them, what they can provide and do themselves. Like there might be some cultural institutions, some gyms or sporting centers, and what other NGOs can be employed or used here to develop an integrated plan. So this is the immediate goal that we are facing for the short-term future, and hopefully we will soon find a solution for this. At least next year we have plans to develop recommendations for territorial centers for such social rehabilitation, to further develop the legislation on this matter. So we entertain a hope that it will be a reality soon. Speaking about other things, or rather questions that I mentioned here as challenges, what is it important to work on now? Out of everything that I've just mentioned, it quite could become more obvious to you that everywhere I mentioned either the elderly people or people with disabilities, but there are also groups of people who do not have established disability, or they haven't reached the pension age yet. They can find themselves in a rather difficult situation, and for them a separate solution will be required, or state-run institution simply will not be in a place to provide them such assistance. The same would be true about their family members. Still, we haven't changed the vector completely. I wouldn't call this an established trend to work with a person who shows some signs of being in a difficult situation. A person with a mental illness, our state-run system is oriented or focused on providing their services to such persons, only to this person, and not to those people who are next to this person. And in that sense, it would be equally useful to develop other types of services, and I'm sure we'll be moving forward in this, on how to consult and advise and supervise people around persons with mental illnesses, how to provide integrated assistance to them, and how this assistance could be more targeted and integrated, holistic, not simply to ensure their rest period during their family members' stay in the daycare centers, but rather reorientation with certain goals and objectives to achieve certain effect based on the individual idiosyncrasies of the person. And in that sense, I believe that such two things on what should be done in what direction must ensure, and the ultimate goal for us to increase the quality of services provided so that these services are adequate to the requirements of our citizens, so that they would take into consideration the diversity of their life strategies, including people living with mental disorders. It is especially important for them because the range of mental disorders, even the difference between cognitive disorders and other spectra, is huge. And here we're talking about different types of volumes and the nature of support required. Also working with the family members so that they don't do more harm than good. And naturally, it would be impossible to do without properly trained personnel. Like the counterindications have been cancelled already, but to make sure that we can work with different levels of disorders, for that we need specialists who fully understand how to effectively communicate, how to set these new objectives within this rehabilitation exercise, and such specialists within the social service system are very few and far in between. We need to train more of them, and the specialists also need to fully realize what methods to use, and the environment within the daycare centers should also be comfortable from the point of view of people who are visiting these daycare centers. I'm talking first of all the barrier-free environment, safety of the environment, the possibility to decide on the time slot when to visit such centers, and other things. First of all, the main focus is made on the communication and creative work, but again, there is a limitation on how many people these centers can accommodate, whether they can provide productive employment capacities. There are some regions do this. It's great when people can practice some creative work in the workshops, when they can do real things, not only gifts and souvenirs, but also in collaboration with some local industrial companies to do labor rehabilitation so that they could be later on employed by that company. All of this would be very useful if such options are made available. But this is just the tip of the iceberg, because to imagine that a system which has been for a long time quite reluctant to embrace people with mental illnesses, they maybe were belabored by different stereotypes, to expect that they will receive and accept everyone would be too foolhardy at the moment. And that is why I return here back to the involvement of NGOs via the mechanism of state contract as well, to support NGOs who are within the system of social service, have been functioning since 2013, but have been developing at a different pace, not as quickly as we wanted them to, because of different reasons, of course. Considering the realities, I hope that such things will be revised and revisited, because now to cover through the state contract all the differences and diversity of services, we need state order for that, and the work of local community through NGOs and their collaboration with the local communities and those different initiatives who at the level of local communities can be suggested and offered. This is the broadest base of the pyramid here, which is an inarguable resource that can ensure full-fledged integration of these people and removal of stereotypes, which frequently are more in the way than the actual physical barriers. In fact, that's all I had to tell you. That would be the end of my presentation, hoping that soon I will be able to tell you how people are making progress along this change pyramid. Thank you very much. Natalia, can you hear us? Yes? Perfect. The question that was mentioned by one of the participants, did you hear it? No, I couldn't hear anything. There was no sound. So it was the following question. As part of the convention ratification on the rights of the people with disabilities in Belarus, the convention includes such thing as a reasonable adjustment. And are there any particular steps made at the national level to implement this principle in practice? Thank you. Well, here, from the standpoint of civil servants, I think it would be more convenient for them to answer, but I can tell you only what I know about this. We did have a few things, like for instance, we have activities in our state program implying gradual adaptation of existing facilities and the introduction of new facilities better adjusted for people in needs. Also, we are going to implement soon a new database that will take into consideration all the existing facilities in terms of their accessibility to people with disabilities. And if I'm not mistaken, in 2018 or 2019, upon the instruction from the Ministry of Labor, we were developing recommendations based on the convention and the norms of various technical requirements and regulations. I'm talking about the adaptation of the environment for people with disabilities to assess the accessibility for different people with disability. Not only wheelchaired people, of course, also people with intellectual disorders, so accessibility to them, various facilities and services. And such recommendations have been accepted by our colleagues from the Ministry of Labor, and they were submitted to local authorities, and they had been submitted to other supervising bodies to be used there. I also saw them on the sites of local governments. So this is what I know about this. Thank you very much. Now, if there are no further questions, we're going to move to our next presentation. Now, I would like to give the floor to our colleague from Finland. His name is ESKO HAINNINEN. He's an expert of international mental health policy recommendations as defined by United Nations. From World Health Organization and European Union, he has been working for a number of years at the State Service of Finland in different positions and the healthcare system and social service, and for many years he had been adopting and introducing in Finland the clubhouse model, and now there are a total of 25 clubhouses in Finland, the ones which provide services to people with the mental health history at the local community. Esko, over to you now.
But I can still start, I think, so to save the time. You already heard my background in the field of social and healthcare service, mental health sector included in my professional background and career. But today my aim is to tell from the general point of view the evidence on positive influences of the psychosocial clubhouse model and psychosocial rehabilitation approaches, where the clubhouse model is one of the many, as a part of the future community-based mental health services. That is the objective that has been defined in many international governmental organizations' recommendations for the future mental health structures in all countries globally. But the situation is very uneven today, so that only part of countries have developed the community-based mental health service structures and systems already quite advanced situation, but many part of countries globally are still in the phase that is based on the old times paradigm where the human rights and practices in the mental health services were based on the hospital and residential institutions. But my main message as when I start my presentation is that from the scientific point of view, the strict biomedical mental health approach and understanding has been already replaced in the international recommendations for mental health development by a more holistic approach that understands mental health and mental disorders as a result of complex interactions of both biological, psychological, and social factors, and a different kind of environmental factors are also included in the social factors. This more comprehensive approach for psychosocial rehabilitation contributes to the recovery and social inclusion of people with mental disorders into different fields of all people's everyday living. This understanding of the more holistic approach for mental health and mental disorders is already, excuse me. Okay, yes. Okay, and when I think that when I heard already and understood from the first presentations today here in this conference, despite of the recent very positive development that have started already 1 decade or 2 decades ago, the mental health service structures in post-Soviet Union countries is today like upside down pyramids, where the most of all mental health resources are used in institutional settings and mental hospitals. And this situation is the obstacle for real development of the flora of community-based services for people with mental disorders. And this is very big challenge. Yes, thank you. This is a very big challenge for all authorities and at national level in all countries and regional level and local level responsible organizations to change this traditional structures to this community-based system where the major part of resources, human resources and all other resources, localities and so on should be used to strengthen the community-based mental health service system, for example, by start of the next decade, I mean 2030s. And when we think how this change process is possible, it is not possible to implement very quickly. We have the experience in Finland and many other countries in Scandinavia, and all countries in Scandinavia, and many countries in Western Europe and in Canada and USA, that it takes time, but it demands. But there are some requirements, and to realize this important change process, a strong and sustained commitment, both political decision makers and mental health professionals, even for a decade or two, are needed to step by step develop this community-based flora of mental health services that are person-centered, needs-based, and respect human rights and recovery approach. So the next slide means that these international intergovernmental organizations launched since 1990s more than 40 different mental health policy recommendations, at least a couple or several recommendations by different organizations, international organizations, for each decade. And the most important guiding recommendation today is the general framework that is created by the United Nations Convention on the Rights of Persons with Disabilities and its optional protocol, adopted by United Nations General Assembly in 2006, that came into force in 2008. The convention includes also all people with mental disorders, and this means also that these people with any kind of disabilities means that also many other long-term diseases are creating disability conditions, and in addition, this United Nations Convention includes both these people with mental disorders and other people with long-term diseases. This recommendation is legally binding in the United Nations member states after ratification, and that has happened also in the Republic of Belarus. And also European Union as a whole has ratified this convention in 2010. And next slide, I have the list of the different important recommendations for mental health policy development during last decade. First one was this World Health Organization's so-called pyramid framework for optimal mix of mental health services, and also parallelly with this recommendation, also the community-based rehabilitation guidelines were published in 2010 jointly by World Health Organization, International Labour Organization, and United Nations Education, Science and Culture Organization. And then the next one important guideline were based on the European guidelines on the transition from institutional to community-based care, social and health care, published in 2012. Then the next year, 2013, World Health Organization's General Assembly accepted a comprehensive mental health action plan for period of 2013 up to last year, but this comprehensive action plan decided to be continued in May last year up to year 2030. And the latest and very important and very actual guidelines today are the World Health Organization's publishment of new guidance and technical packages on person-centered and rights-based mental health services that was launched 10th of June this year. So this is very new package of recommendations due to be realized and taking into account in the mental health policy and service system development in all World Health Organization's member states. All these above mentioned guidelines and recommendations are built on the regulations of the United Nations Convention on Rights of Persons with Disabilities, like I told just in the previous slide. And the next slide is giving the understanding what is meaning, what are included in this World Health Organization's new community-based mental health guidance and technical packages from this year, June this year. And you can find all these recommendations and main guidance recommendation booklet from the World Health Organization's website, and then there is also this downloadable all material which is included in this guidance to promote person-centered and human rights-based approaches in the mental health services. And the package includes this main guidance book and 7 other technical recommendation sub-booklets. And the first one is the recommendations for mental health crisis services, how these should be developed. And the second package, second guidance technical part includes hospitals and human rights issues that should be taken into account in the hospital care. And the third one is concentrating on community mental health centers. And the fourth one is concentrating on peer support mental health services that are very strongly developed to be taken into account, like these community mental health centers development. The fifth one is also included partly on these previous recommendations, technical booklets. This is community outreach mental health services, because in many and most of countries actually in Europe, a big part of the people who should need mental health service support for their recovery and coping in the society, these outreach services, but only part of these people, all people who should need the mental health service, can have actually in actual life these services for their support, for recovery support. And the sixth technical part of the recommendations include the supported living services, which means living housing systems as a part of mental health policy, and other support practices included in this supported housing system. And the last one is handling this comprehensive mental health service networks, which is some kind of end result or end outcomes of all these recommended operations and new type of services which should be included in mental health service systems and mental health policy in all countries. And to be mentioned that psychosocial rehabilitation in general and the Fountain House clubhouses as centers, mental health centers are included in part 3, these community mental health centers. The next slide is concerning because in the background of all these new recommendations of World Health Organizations and other and international institutions are based on scientific research, and the main questions, of course, is why we need research on outcomes of psychosocial rehabilitation models and in the community-based practices in general. The background for this need is that all activities that are funded by public money everywhere in all countries, more and more scientific evidence is expected on the impacts of the activities concerned. And the other reason is that why we need this comparative research and basic research is that the outcomes of this all research and study reports must be informed effectively both to the mental health professionals and political decision makers in all countries. And then what is the research in the context of rehabilitation is the theme of my next slide. Scientific research is comprising creative and systemic work undertaken to increase the stock of knowledge and the use of this knowledge to develop existing practices and services. That is defined this way by Organization of Economic Development, OECD, a couple of years ago. But there are different approaches of scientific research in the mental health field. There may be either restricted approaches restricted to biomedical methods, and the problem is that this approach provides only biomedical results and outcomes, and also biomedical interpretations from these studies and research. Or the scientific research should be and could be based on understanding of people as a integrated biopsychosocial human beings that provides, and this approach provides a wider understanding and results what is happening in the mental health field and the outcomes of the different mental health service approaches. The conclusion is that research on the psychosocial rehabilitation and clubhouses as part of these psychosocial approaches should be based on this wider multi-scientific and multi-sectorial view that is studying recovery outcomes and service influences of services also across different organizations and different administrative sectors in society. And the next slide is giving the understanding what are the main dimensions of the clubhouse model as an example of psychosocial rehabilitation approaches. You see that the clubhouses as a center of many activities are very multidimensional approach to support people with mental health, different kind of mental health disorders. And actually, this model has been since the beginning already based on the needs of people with mental disorders and they are person-centered and based on the individual resources of all mental health people with mental health problems. And also, since the beginning, the Clubhouse approach included the high requirements concerning the human rights requirements. And the next slides gives the idea behind the recovery processes, because there are several perspectives to understanding what is recovery. In many people even today are understanding that the so-called complete recovery means that all identifiable symptoms of mental disorders are disappearing. And then the clinical understanding of recovery process is that the clinical professionals are based on their work, support work to management of diagnosis-related symptoms with help of medical treatments like medication and different kinds of psychomedical therapies. And then the third perspective for the recovery is the functional one. And the main focus on this understanding is on a person's functioning abilities, which means how well he or she can manage daily activities. And the fourth view of recovery understanding is a social recovery. That means that a person becomes able to perform the major social roles in the normal everyday living situations in the local communities. And recovery is always very impersonal and unique process. And the Clubhouse model and many other psychosocial rehabilitation models focus on supporting the strengthening of functional and social recovery understandings. And the next slide includes the summary about international database on research findings, which you can find from this website of the Clubhouse International's website address you see in the upper part of my slide. The main summary of these hundreds of internationally and country-based scientific studies have provided the outcomes that regular participation in the Clubhouse or other same type of psychosocial rehabilitation activities will provide firstly, members' recovery, well-being, and better quality of life. And secondly, the participation in these activities reduces the use of hospital care and outpatient psychiatric and other social and health services. And this reduce of the hospital care, need for hospital care and the resources for hospitalization are decreasing as one important outcome. It is very important part of these positive outcomes, which gives the possibility and outlook for using the resources that are today included in the hospital-based system. Part of these resources could be and should be removed for the strengthening the community-based service service system. And the next summary includes that the participation in these activities motivate members of clubhouses and other psychosocial rehabilitation activities. They motivate people to education, learning new skills, vocational training, and mainstream employment possibilities. And the next one is that important fact that clubhouse participation also are very important when we think the costs and the money, how we can use the resources, and the participation is the community-based psychosocial rehabilitation and clubhouse activities provide cost-effective investments for the funding agencies and the society as a whole. These findings are validated and repeated in tens of research reports in different countries and cultures worldwide, also in Finland. However, the clubhouses or other clubhouse or other psychosocial models do not satisfy all. There is not any such kind of model that fits the needs of all persons with mental health problems. That's why there is a need for other types and forms of daily programs, participation programs, and approaches, and also the less goal-oriented actions, and also recreational service and cultural service, etc. And then the next slide is giving the understanding what are the outcomes of an international survey realized in 8 years ago, coordinated by the World Federation of Mental Health and provided by Patient U organization. And the result of this international users and their carers survey are that the main challenges and priorities are in the relation to social inclusion needs of people with mental disorders, that they are expecting, people with mental health problems are expecting that in addition to medication and other medical therapies, there is also needs for education support and giving more information and support for using these educational and learning possibilities. The second one is also that people and their carers are needing support for their employment and job placement needs and support for these approaches. Also, there are needs for support to more independent living and housing services, because in many countries, major part of the people with mental disorders are living in their families, childhood homes, even when they are also in middle age, and that is not so-called normal situation. That's why also families and the person themselves with mental health problems are needing the independent housing and support for this independent living arrangements. Also, the many forms of discrimination are identified and perceived in the local communities, and as a whole, to be summarizing this, the real unmet needs of mental health policies in most of countries in terms of social inclusion objectives in the mental health policy. And the next slide is consisting a lot of essential research findings on a growing area of research, which is including the educational and the learning impacts on the recovery processes of people with mental health problems. And that is very important and growing sector of research area in this field. And the participation in the adult education helps people's well-being, general well-being and recovery from their mental health problems. And online information is available very much from this website address, which is the website address of the European Association of Education for Adults. And there are a lot of information about this adult education impacts and influences on the supporting the recovery of people with mental health needs. The second part is that learning the realities of the mental illnesses and prospects for the future could be promoted by organizing psychosocial courses. That means learning sessions and regular meetings of professionals and person with mental health problems, their nearest ones and friends together. And the best description of this psychoeducation programs is available from the Wikipedia website, which you have the address also included. Recovery education is a growing way of working where the expertise of service users, family members, experiences, supporters and service providers understandings are accepted, valued and utilized to ensure better recovery outcomes for all in need. Recovery education can be delivered across a range of venues, for example, in recovery colleges. That is a very rapidly growing network of recovery education organizations in different countries in Europe and worldwide. And there are two examples websites. The first website is concerning the recovery college practices in Ireland, and the second one is the English language website from the recovery college practice in Finland. The needs-based adult learning courses in general could form part of the solution for people who have less severe symptoms, as well as for those who are already on the road to recovery from a more severe illness. And more information about this approach is available from this website of a mental health foundation organization in the United Kingdom. And there has been implemented a very, very interesting study during last decade concerning the learning for life. And that is that gives very positive outcomes concerning this recovery education. The positive outcomes of the adult education courses in different settings are confirmed by the research that learning new skills help people in their social and functional recovery and strengthen their coping in changing labor market and a digitalized society in general. And there are also very important sources included in this part in this slide, and very important background document is 10-day-old European Union Council resolution on a new European agenda for adult learning during this decade that was given 10 years ago in Brussels. And then also there is very important study report of UNESCO a couple of years ago concerning third global report on adult learning and education, and that is available from also this website. And then there is very important European international educational study called the BELL study, and that is available from website that is also included in this. In this. Have I already time left? Yes, okay, let's continue. I give only one good practice example from Finland, because the Prime Minister's office ordered in 2017 from a partnership called the Minds Together to provide decision makers with evidence-based information about effective models of mental health and addiction services. The partnership was consisting of internationally known mental health researchers, and the main findings are presented on next slide. And the main evidence-based findings of this research partnership, please, next slide. And the main evidence based of this partnership studies are related to community-based the community-based psychosocial rehabilitation is that the clubhouse model in general was noted to be evidence-based model. Individual placement and support IPS model, like in many other earlier studies, also in this study was noted to be evidence-based. Inclusive daily support activities organized by different ways in different situations in different communities, and the first aid training for self-management for mental health problems is also identified in Finland to be very helpful to support people in their recovery process. Also, the support based on expertise of experience and peer support, that is also growing area of social practice in many settings of mental health services today in Finland and many other countries. Also, there are excellent training programs for the experts for experience for people who have the mental disorders. And then supported housing approach and short-term psychotherapies are also included in these evidence-based psychosocial rehabilitation and recovery support models. Also, the promoting the practices which promote the motivation to education and employment are evidence-based practices. And then the support for learning healthy lifestyle and healthy cooking are part of many psychosocial service units today. And to summarize, many parts of this list of above mentioned activities belong already to the clubhouse programs. And then I refer in the next slide to a international systemic review report, which is evidence-based for the psychosocial rehabilitation and clubhouses worldwide. And there are strict scientific evidence that this psychosocial rehabilitation clubhouse model is really evidence-based as a multi-dimensional service approach. And then I give to my end. So how we can provide the best value for the money invested in the mental health service development? Please, let's go further. And as an example, we have made in Finland calculations and studying this cost effectiveness and compared the costs of the hospital-based services and institutional-based services to the community-based service examples, and these are based on information from Finland, but also in other countries have been made similar studies. The annual costs of 1.5 or 2 psychiatric hospital beds places are the same or higher than 1 year budget for an empowering clubhouse for 30 to 35 daily attendants with mental health problems. And this year budget of empowering clubhouse include the rent of the space, equipment needed, and hiring the staff as director and 4 to 5 staff members. But the same is true also in other similar type of support activities as a part of the new flora of community-based services. And that's why this is very important message also concerning this cost effectiveness of this psychosocial community-based development. To conclude my last slide, we need in Europe in general a community-based mental health policy where the psychosocial rehabilitation and support models have a clear role as contributors to develop a new community-based mental health services system in as many countries as possible. The more service users have low threshold possibilities in the local communities for psychosocial support, the more cost-effective the new system will become, with benefits both for service users, which means people with mental health problems, and their nearest ones, and also to funding authorities in the savings and better return of the money invested in the mental health new community-based service system development. I thank you for your attention.
Now we're going to get feedback from our colleagues. I was attentively listening to the previous speakers, and in fact I had a feeling how much we have yet to do, how much room for improvement we have here, because mental health is a very vulnerable sector. It has always been a taboo. We've never had a direct access to it in the past. Naturally, this subject matter is perhaps less developed in terms of the involvement of communities here, because mostly only highly narrow specialists were talking about it. And when we speak about civil society, that's why we observe such a huge slump in our knowledge, because of the taboo and stigmatization of this issue. But now we have a state-run system of both healthcare system and social protection and many other departments who at the moment already have some experience and resources that help people with mental conditions to encounter and to combat their problems. Now I can switch over slides, but I cannot switch them over from here. Okay, and everything is jumbled here. Distinguished you also have this jumble in your slides? Same jumble, right? Okay, doesn't matter. I'm going to page through slides and look at the screen at the same time. Okay, let's do it this way then. We were talking about this, that we have a national program in place that was approved by the Council of Ministers, and it is the National Strategy of Active Aging 2030. And of course, this active aging contains the main principles, creation of enabling environment for fullest implementation of not only potential of the elderly people, but improvement of their quality of life as well. Speaking about the quality of life, unfortunately this slide is jumbled, but it is in the center of all things. The things which are around it, that would be social aspect, medical aspect, and spiritual aspect, and the aspect related to the mental health of that individual. So these are equal aspects from the interaction of which, and the interaction of different agencies, including governmental, non-governmental, depends the quality of life of our people. Now I cannot switch it from here. I apologize, dear colleagues, for the technical difficulties. I'm switching it over in the PC now. Okay. Good. Now, the quality of life of the elderly, the mental dimension of it, whatever is related to their livelihoods. And if we look at the available statistics, we always are inclined to analyze numbers. And these numbers clearly demonstrate what is the huge need of people in the medical and social assistance. What is a medical and social assistance? That includes both medical and social aspects. Virtually 93.4% of single and lonely elderly people require medical assistance, and about half of them require individual care. And here we still have a question to answer: who will be providing this care, and how difficult it is for those people to get the full range of services required for them for proper livelihood. 87.4%, almost 90% of those people require social services. If we look at these numbers from the practical dimension, virtually all the people with disabilities, virtually all the people with the livelihood difficulties and the quality of life require both medical and social services. And of course, when the study was done and the question was asked, what model of life is preferable for a person with any kind of illness, be it mental illness as well, what kind of model they prefer, whether they want to stay in an institution or whether they want to stay at home. As you can see on this slide, more than half of the people answered that they want to stay at home. But staying at home, they still require getting their social and medical services and other services in full, in-house. This way, we're talking about reorientation of the medical and social assistance, which should build on the principle of the model aging at home. And this model is much more economical, but it also implies reformation of all other systems, and this system of continuous provision of medical, social and other services when a person would be able to stay home and acquire the whole range of services and not to lose not on their quality of life, not on the quality of the services provided. Who can be a provider of such holistic services, who can provide all the services that we're talking about here. First of all, that would be the outpatient clinics. And secondly, that would be our centers, territorial centers of social protection, which employ also quite an army of specialists who provide such services routinely. If we speak about the outpatient clinics from our healthcare system, these are the organizations in the healthcare who have such a thing as visiting their patients at home. They can provide their medical assistance in-house, at home of the patient, not in institutions. And here, the range of available specialists is quite big. But please note, out of all these medical and social services that we have, both in medical and social aspect, if we speak about the healthcare system, what kind of services do they provide? Of course, by default, they provide medical services because that's their specialization. If we speak about the territorial centers of social service and the system of social servicing, what kind of services can they provide at home? That's right. Mostly it's social services. That includes social service and utility services as well. But what is the need of persons that they testify to, especially people with mental illnesses, with some physical disorders that can make them dependent on outsiders' help? First of all, they're talking about individual care and psychological aid. And please see here, do we have in the existing structures or organizations services that provide or that are provided based on such holistic approach? No. We're saying that now, practically speaking, this is a blank spot or a gap that we have. This gap is not filled in by neither of the available structure. Then who should be those people? Volunteers? That's a question. Why? Because a volunteer must be properly trained to provide such individual care service. This is not just a care, like earlier it was done when a person comes, feeds such a person, some other homely things done. Now, people who are checking out of the institutions who have problems of mental or physical disorder, often they are bedridden patients who have huge problem of taking care for themselves, like it includes gastrostomes, colonostomes. The patient has changed. Basically, a profile of the patient who stayed at the institution in the past, now they prefer to stay at home. Then who should be taking care for them? Now we approach a new role of a specialist. We look for such a specialist which does not only have knowledge but also practical skills and who can appear in the system to provide such a range of services. If we speak about a model, then the future model here would imply integration. Today we have gathered here today medical professionals, social workers, NGOs, because our model cannot be successful if we do not integrate when we subdivide our needs and functions into different competencies that we have and create a system of continuous assistance to a patient who is dependent on outsiders' help. That's why now the biggest priority for us is the personification. I watched the previous presentations and they were about a new system which is a patient-oriented, patient-centered system. We're not telling the patient what that patient needs, but the patient tells us what they need. So everything is centered on the patient's need, on the patient's vision of his or her problems. That's how the system should be built. That's why we need a new specialist for that, because patient profile has changed. The patient needs have changed. Often, patients who stay at home, There are patients who have artificial breathing apparatus, or patients with significant problems which must be maintained and serviced by specifically trained professionals. That's why therein centers the need for personification. We're not talking about, globally speaking, about the patient with the first group of disability. No, we're talking about what kind of problem or challenge this person has and how we can satisfy such needs. And from this comes the second question. How can we service such a need? For that, we need to do the needs assessment. And not only assessment, not in the form of rehabilitation, whether this person needs diapers or not. No, rather we have to study what kind of problems this person has, both functional and physical and social, and in what environment this person stays, and how we can offer such a person a service of such a specialist to meet such a need. That is why in such an integrated model we are changing our approaches. This way we are approaching the system of the so-called long-term approach, long-term care. And when we see that our patient is checking out of an institution and they require some social or medical aid, all these questions must be answered right there while they're still in touch with the social workers and medical professionals, and they shouldn't end up in a situation when they return back home and spend a long time when they try to find a solution to all these problems via social services. They should already be, a follow-up plan should be provided with a whole complex of services required for such a patient. I understand the irony of the issue, but the thing is that this is the ultimate goal that we need to try to achieve. If we do not establish a system, which at the moment I would say is rather totally randomized. We have strong medical assistance system, we have strong social service system, we have strong NGOs, but we need to integrate all of them to make sure that, most importantly, we don't lose the needs of a person in this. On this slide, you can see some of the elements of the long-term care which is required for subsequent development. I'm not going to speak more about this because otherwise it will take me hours to do that, and I simply will not fit within the time parameters I have. But most importantly, this theme implies an integrated model where we would not lose the sight of the person's needs. One will be following it from the beginning, the onset of problems, until the situation when we fully satisfy these needs. Here, the main focus of our organizational structure is the team approach. You see, we have a team of therapeutical station. This is the front-end team. This team is working. This team is annexed to both gerontological and geriatrical services. Yes, we have well-working teams indeed, but at the moment they do not have good interaction when we would be able to say that yes, they are working continuously, and we know very well where we have slowed down aspects. But in this team approach, I would also like to see other teams, the teams of NGOs, teams of volunteers, teams of local communities who would be joined together to implement this interdisciplinary and intersectoral and, most importantly, human-centered problem. If we speak in the language of numbers, you know that the system of healthcare system is the system which also cherishes its resources and allocates them to the most important priorities. And then the healthcare system, we see formation of the geriatrician or geriatric approach. What does it allow us to do? On this slide, you can clearly see the numbers that other countries boast now in terms of the saving of resources with the integrated geriatric examination. Why? Because here they're assessing not simply the illness of a person. We're not just saying this is the elderly person with arterial hypertension, for instance. We're saying this is a lonely person with arterial hypertension, with the heart problems, which does not allow this person to go shopping and buy for oneself all the necessary foodstuffs. This person is having some mental conditions which prevents him from servicing oneself with, again, some foodstuffs or products without disturbing his mental condition. And through this needs assessment, a person is examined in a 5D system when we decide what symptom is prevailing at this particular moment in time, what affects the dependency of this person from outsiders' assistance. Can we, medical professionals, improve this component, or this component should be affected by other structures, like the Ministry of the Interior, for instance, if we're talking about the domestic violence? Or is it the social protection system where the principal factor is lies in the social dimension? So the integrated geriatric assessment of a person includes all these components, which in the final analysis will provide this person with the roadmap and the service which is highly personified for this particular person. This way, the chance for success is increased ever so much more. And this person then is not institutionalized as a result, and this person, whenever possible, stays at home to make this model, again, more successful. What are the current barriers do we see here? Why do we keep talking about integration for many years, and which barriers do we see? In fact, at the moment, both medical and social fields live through the constant reforms and reorganizations. But the thing is that this question, related first of all to the mental health, is taking so long to solve, because if the medical health system is developing mostly within psychiatric assistance, and at the moment we identify the problems with mental health at quite a late stage, and the social service is also facing a barrier related to the notification principle of acquiring social services. What is the notification principle? When the notifier himself or herself must tell you or notify you about the problem and appeal to the social service. So we're talking about this the active detection of problems is virtually non-existent. And also we have other problems on the repetition of reporting, and needs assessment is a problem. And these are the barriers which can be overcome with the proper system of medical and social service in place. Here we must be talking about new competencies for social workers, new competencies for medical professionals, and priority number one for us here is to change the status of a social worker. We're talking about totally different functions, totally different approach of the population as such to the work and contribution of the social worker. And here it is very important to have people, the systemic people as I call them, who would be following up our patients. We have such a project running now on case management. So this case management project is of utmost importance, because to learn to see a problem, a person's personal problem holistically, and be able to follow up this person through all our intricate routes and zigzags so that the person would get highly satisfying service. This can be done only by the person who knows how the system works and who has the skill set of how to properly assess and connect and refer to proper specialists within our system. And of course, it doesn't appear out of its own accord. And now I would like to share with you one example based on a dementia case, where do we start having such problems? Very simple, everyday cases which will paint you a picture how we should develop onwards, and how important is the role of NGOs here. Now, for instance, our understanding or idea about dementia in the society where we live, mostly people are talking about the stories of their relatives, which are very similar to each other. For a long time, family members ignore the idiosyncrasies of an old woman, and when these idiosyncrasies become harmful to her health, when the old woman starts living at home without switching off the cooker, the red flags start to rise when the members of the family appeal to specialists. Why, you can ask me. I know this because, unfortunately, right here, I'm going to tell you about this slide more, because in fact, only 11% of family members are properly informed about dementia. 11%, that's almost nothing. When people who are supposed to know when they live with an elderly people what kind of problems they might face, what they should be mindful of, because the person himself is not always in a good position to adequately assess their condition. And more than 80% would be those people who have heard something about such a problem. And mostly that would be people who have never heard about this. For them, it's like came out of the blue. Speaking about the problem which is reflected in the medical sector, when the family does not know about this, when can the patient end up in the medical service? Only when dementia is highly advanced and severe. Practically speaking, more than 50% of this would be people who would end up in the healthcare system with a very advanced and severe case of dementia. No preventive measures will never work under these conditions, and we'll have to follow up this person as a person who requires more psychiatric assistance and social assistance, and frequently they would require institutionalization. So what is our ultimate goal? To make sure that the bottom part of this iceberg, the iceberg part underwater, so this part of people would emerge and would not go to a psychiatrist right away, but rather go to a specialist who is in a position to help this patient who starts showing first signs of dementia, and work with them on the issues which can either stabilize their condition or lead them to a long-term plateau under which this person will be able to live independently from outsiders' help. Because we know what psychiatric field is. What are we concerned about? We are always concerned in our family that one day or another we'll have to take care of our relative because they simply will not be capable of taking care of themselves. They won't be able to take care or service themselves, and would be unsafe to leave them alone. And I'm saying it for a reason, because at the moment we have numbers. Numbers show that 70% of those people who provide care at home are mostly relatives, next of kin, like daughter or son or a spouse. 20% is done by other family members. It is quite a challenging situation. And additionally, also as a rule, the caretakers who take care of those people who show initial signs of dementia are themselves in the 70-plus age group, whose dementia developing risk is also quite high. And, of course, 40% in this case, 40% of families who might create GDP, they are outside of the labor force because they have checked out of the labor force, and economically speaking, this is a very difficult situation for such a family. That is why social consequences of such actions are huge, because we're talking about rising costs, reduction of labor intensity, reduction of the quality of life of people in such a family. Often we have a burnout syndrome in such a family, and these people and family members also require assistance, especially when we're talking about elderly, taking care about the elderly. Often we see among our patients also those people who are caretakers because they start developing psychosomatic conditions, and social consequences of the lack of such early detection system or the lack of information and awareness raising among the society cannot be overestimated. What are the growth points that I can mention here? Naturally, they include competences. And if we speak about competences, the competency of a family, competency of medical professionals, and the competency of social workers. And of course, those people who are next to them in the society, because any referrals of a person with mental conditions or dementia happens at a very advanced stage, and it happens late also because all these three components of the competencies are not developed sufficiently enough. But naturally, in our national center, we pay a lot of attention to this problem, and we have whole departments equipped with very highly trained special personnel, knowing how to work with psychosomatosis and how to work with mental patients. And here we have specializations like geropractices. These geriatric practices are based on the customized and personified assistance. We're talking about geriatric awareness raising of patients themselves. And when we started to focus on patients themselves who are staying at our hospital, we saw that this work alone is not enough, because when we refer or send this patient back to the family is not charged enough to show enough understanding, and those gero practices that we started to develop would be continued in the family. That's why we now decide to organize schools of support and care. These schools have been working quite well, and they're not only about assistance to patients who require such active care, but they're also focused on the family members of such patients who are not sufficiently informed on some of the nuances and skills how to work with such patients. We also have another interesting running project. This project has been joined by all our clubhouses. I know they enjoy visiting us, and we're grateful to them for that as well. And this is a great platform for collaboration between NGOs, society at large, and the governmental system. This is a project called Free Time Bank. Our volunteers who are using art therapy and many other directions and activities to support the psychological status of our patients. And this project, if you want to, you can visit our webpage and read more about it. I would consider it a successful project. What else do we have in our plans? We plan to create a platform for training. Now, our department, medical practice department, is preparing a whole cycle of training courses to train not only doctors and nurses, but also to train social workers and, generally speaking, people who one way or another are related to mental health issues. And naturally, the time is not standing still, and without such an information resource as a information portal, we simply cannot move forward. That's why at the moment we have such a portal called Senior Bell, the portal that will serve as a navigator for patients in terms of providing them with the medical and social services and caretaking for the people who encounter this in their life. Naturally, the word integration is always a uniting word, but now we see a resource in this integration, which is the work with the families, work with the society at large, because this is a great impetus for all of us to show high quality of our work so that we can hear and listen more to the needs of people related to different challenges and problems to make sure that our work is a success. Thank you for your attention. Lyudmila, we have received a question from YouTube now. The question is the following. Are there any medical practices to assess cognitive status of a patient? And can social workers do such an assessment, or you need a special medical training for that? You know, colleagues, in fact, this is a problem. Why? Because when we started to introduce different testing practices and questionings that helped us to identify the cognitive capacity of a person, some of these questions can easily be asked by a person without any medical education, and we are going to share such practices with our social workers and the people who have some doubts or suspicions at home that their relatives might show some cognitive disorders. And very soon, I'm sure you will hear about the introduction of such a project. Now, so far, this project is moving along our regions, but hopefully the city of Minsk will join us soon in this endeavor. Yes, there was yet another question. The psychological assistance on how to support. Are you going to train such specialists anytime soon, how to provide psychological assistance? Of course, dear colleagues. Now, when it's still in a rather rudimentary stage, we believe that as people who work in the both training and in medical field, and who are deeply aware of the problems related to a mental condition of a person, we believe that, of course, such training must be organized first at the level of our medical universities and institutions. In future, though, I think it would make sense when preparing trainers who we shall train for NGOs and many other, maybe clubhouse models, so that these trainers could work at such interdisciplinary platforms. But the beginning of this should be started by the highly skilled and knowledgeable sector, because you know, mental health sector is very subtle and sensitive thing. If we try to do it bluntly, we can do more harm than good, and our main motto, not to do harm. Yes, colleagues, in fact, I'm going to read yet another question, and will provide some comments to our viewers from YouTube. The question here is, can psychologists do corrective work with a person who has been deprived of legal capacity? Would that be legally possible? Maybe Konstantin can comment on this. Just a very brief comment on this, dear colleagues. What is legal incapacitation? This is more about legal status of a person than a medical diagnosis on the nosological level. That is why everything depends on what is the nosological form or shape of a person, whether this person requires psychiatric, therapeutical assistance, and such a decision has to be made by a specialist. And if there is a question whether you can do it or not, the first specialist who will decide it would be the psychiatrist. Okay, thank you very much, colleagues. Now we're going to have a small break, and we will regroup here again at 3 p.m. You don't have to switch off your Zoom platforms, or because later on we'll have a presentation from our colleague from psychiatry, head doctor from the dispensary clinic, Alexei Alexandrov, and also our colleagues from foreign countries who will speak about their support services for mental patients and their family members. So we regroup exactly in 15 minutes. You had enough time to recharge your batteries. Now I'd like to give over the floor to our colleague from the healthcare system, Alexei Alexandrov, who will tell us about a system which is now in place in Belarus, the mental health system. He will speak about the current situation and the support services and prospects of service development in Belarus. Over to you, Mr. Alexandrov. Здравствуйте, уважаемые гости из разных стран мира. Now I'm going to share my screen. I tried it previously and it worked. Rectified. Okay, while they're solving the technical issue, I would like to briefly tell you about our organization. We are working in the city of Minsk. We're servicing the territory of Minsk and the Minsk district. We are servicing about 250,000 people of the Minsk district. That's a special district without a district center. The only relatively large center would be the town of Zaslavl, not far from Minsk, and the advisory assistance is provided to the residents of 1.5 million residents living in the Minsk district who live around the city of Minsk. Again, the unique status because it doesn't have any district center. Our center is integrated, and a similar center in Belarus is established in Vitebsk and in Grodno. These are the centers which have united the old conventional system that's separate to psychiatry and narcology. We're called Minsk's Clinical Center of Psychiatry and Narcology, and the similar centers exist in Vitebsk and Grodno, as I said, but in Gomel and the Brest region, the city of Minsk, and Mogilov region, they have two different organizations, two services who are still working separately or rather parallel to each other. Today, anyway, I'm going to tell you about the mental health service. Now I'm going to share with you small information with the comments about our organization. Those people who find it interesting can learn more about it on the site. Out of the additional services that might be useful to those people who do not live in the region of our coverage would be our emergency psychiatry hotline. Of course, such hotlines exist in different districts. Whenever you need to get this quick assistance, you can call us on this hotline. And while my slides are being uploaded, maybe I can try to set up my screen again. I'll try to set it up. Okay, I'm clicking on share my screen and showing slides. Yeah, we can see it now. You see the next slide now? Yes. Sorry for that. I shall try to do it again. Click on the share the screen. My presentation is there. I click on share my screen. Then I start showing slides. And I click on showing slides now. And you can see my first slide now, right? Yes. After which I switch then to the next slide, but you do not see the next slide. Can you do it once again? Because I'm looking at the second slide. At the top, I see the line that sharing the screen is stopped. I need some technical advice how I can rectify it. Now I'm showing second slide. I've left the slide demonstration mode. Okay, well, I will try to answer the question that was asked today a bit earlier about whether it is possible to advise, whether psychological advice is possible for people who are staying in daycare centers, especially people who are legally incapacitated. There is a special legislation on psychological assistance. Also, there is a special instruction from the Ministry of Health on psychological assistance, where there is a separate question on indeed psychological assistance can be provided to legally incapacitated people without the specification of where this can be done. Of course, it can be done in daycare centers as well, with the one precondition that a consent should be provided from the custodian or the person in charge of this. You saw the diagram there, right? Maybe it was working on my side. Anyway, dear participants, then I will start by saying that the problem of medical illnesses is not unique for Belarus. All the countries next to us and countries of the world are suffering from the same challenges, and in order to compare the situation in different countries, today we heard speeches from Finland. Still looking forward to the contributions from other countries. I would like to show you the place of Belarus in the global indicator, or rather global competition on mental health. And in that competition, those countries shown on the slide now, those of you who saw that slide previously, this slide is about the dissemination of mental illnesses in percentage-wise to the population of different mental conditions and disorders, also from the point of view of the distribution per 100,000 of population. You can see the place of Belarus as not a leader in terms of mental conditions. You can assess it and interpret it differently, but one of the interpretation is that indeed there are some special countries out there with special pathologies and mental health. And on the other hand, we're talking about a high level of dissemination of these conditions when the diagnosis has been done by a doctor already. This is a situation when the assistance is available, and of course, if a person does not apply for such assistance, no diagnosis is made, no services are provided, then it can turn out that the country has very few cases, and there might be a misconception that the country is doing very good in terms of mental health. Can you show the next slide after the title page? Because I start seeing that people are helping me with that. Okay. Out of important things, which I wanted to mention here as well, is that now a lot is being said about the COVID-19 pandemic, and it's being said that it might be accompanied by the growth in mental conditions, and the numbers from 2020 or 2021, when we compare Belarus with other countries, we do not have within the context, I cannot comment anything within this context what will happen by the end of 2021, but if we look at new cases detected for the available years, also from the WHO statistics, we can see, it was the previous slide actually, yes, and now this is the slide that I'm telling you about, thank you. So out of those countries who are reporting this, Belarus again is not among the top leaders. We see Germany there with very high detection rate, but again, it might be interpreted by the better access to the service, by the fact that how people are referring such assistance. And interestingly enough, the information on this data shows the number of people who checked out of the institution system per 100,000 people. Why is this slide important? Because the prevalence and the number of new cases is by far not the biggest, but still there are quite a number of people in Belarus continue to use psychiatric assistance, mostly through inpatient clinics. That's why if we look at the institutionalization level, we see such a high statistics here at the lower diagram of the third slide. And now I would ask you to switch on to the next slide. And here, that was the previous one. Yeah, next one. Yes, thank you. Next. Here, I wanted to tell you about the most famous type of disorder that the maximum number of people are suffering from now. Maximum both in terms of the percentage and the number of appeals. That would be depression among the affective disorders. And here, Belarus, again, is not a unique case. We can compare our standing to the average in the European region. And the average in the region is a bit lower, but not significantly lower than in Belarus. I'd rather say Belarus is a typical European country in terms of the prevalence of depression. But why I'm showing yet another picture here at the bottom, depression is one of the risk factors that can lead to attempts of suicide among people. And in the situation with Belarus, we have quite good standing in terms of the suicides among children. It's quite a low level, but later on I can say that it's very important for mental health, the level of suicides among adults. Next slide, please. Thank you. Now, mental health. I will start with the young adults and youth. All of us have gone through this period. Of course, we here would like to speak more about the elderly, but all of us have children, have people close to us who have children, and at least our elderly patients also have their grandchildren. And it's an important component. The study done in Belarus in 2019 was published with the support from UNICEF, has demonstrated the problem of mental health among children and young adults is important, like depressive disorders are the most relevant, but it was detected with about 18% of young adults, and the factors that contributed to this, the tensions with the parents, and it turned out that girls are more prone to that. That is equally applicable to adult women, actually, and also about suicides in the context of young age, although suicides among children is very low in Belarus, but such ideas about death and suicides often visit children's minds. Every 5th child thought about this, and almost every 16th child had these ideas repeatedly, also caused by the tensions in the relations with the father and depression as a factor contributing to suicidal thoughts, and abusing and bullying is also a risk factor here that contributes to depression, symptoms, and suicidal thoughts. Next slide, please. This study that has been published has demonstrated strengths of our service provision system, first of all in the context of children, and also those places where we would like to strengthen things. Here, I would put it like this. It sounds very similar to what we will tell you about other ages. There are some opportunities here, like we have laws on psychological and psychiatric assistance. It's great that we have NGOs. I'd like to thank the Association of Social Workers here, but also there is a huge stigma, and it is as big with children as with adults, and there is lack of data, lack of knowledge, and of course, in case with the specialized assistance, which on the one hand is available, but on the other hand, there is a wish to get it on the commercial paid basis, and there is deficit of such money or affordability of such services among general public. Next slide, please. Here, I would like to tell you more about what we do. We have implemented a number of projects, and the materials about these projects are shown here as hyperlinks. Later on, I can share these hyperlinks in comments. This is a story about how the child trauma in the dysfunctional families, such families can end up in the socially dysfunctional family status, and this is a situation when the person is experiencing school problems, family problems, or survivors of domestic violence. And there are many NGOs who provide assistance with that, and there are already resources and understanding that mental health of adult people, including also the elderly, starts with the childhood. And we start working with children to put it more ironically, so it would be easier for us later on to work with the elderly, because if people get traumatized when their children apply for social services later on in their life, it will also have a telling effect on the social service provision at any age. Next slide, please. Here, I'm going to show the migration from the deep childhood to more mature age, more golden age as we call it, and one number about dimension, because it's also a frequent condition, and to connect dimension with Alzheimer's disease is by far not enough. There are many other reasons for that, but still it's one of the most problematic conditions in terms of the caretaking. But also this is a disorder requiring early detection and early intervention, both from the relatives themselves. They must be properly educated to know how dementia starts. Dementia is not when a person experiencing hallucinations, but when a person is having difficulties in doing daily care of themselves. And the second thing is that dementia is interregional. There are no special regions in Belarus. I'd like to thank our specialists from our previous speakers told us about what kind of work is done at the level of Ministry of Labor and Social Protection, that dementia covers all the region of Belarus. We can ask why it is so manifested in the Gomel region. In the Gomel region, aside from a lot of dementia cases, there are a lot of psychiatric beds, and diagnosis of dementia there is explained by the fact that the elderly people are placed in the institutions and where they get continuous care. This is a method of managing dementia chosen by the family members of people with dementia. It is easier for them to do it without putting them into social care institutions or without alternative sources of assistance. Next slide, please. Now, I would like to tell you more about how the situation with mental disorders is changing. If we take different diagnoses among all the diagnoses, number one would still be disorders not creating. We're always afraid of some kind of basis to put people in an inpatient clinic, and often social workers are saying that we need to hospitalize this person. The absolute majority of people with mental conditions do not require hospitalization. Their mental disorders do not require isolation or institutionalization. In no way are these people hazardous or dangerous to care providers. Such things, of course, as schizophrenia or the absolute minority of the number of mental disorders, of course, in acute phases and forms, they require medical and medication treatment, but even later on, the life of this person with such diagnosis should not be limited with the walls of a mental clinic. Such cases are very, very rare. Next slide, please. Here, I would like to draw your attention, thank you, to how many people in Belarus we have. And here you can see that such numbers are enjoyed by specialists, that 3% of Belarusians are suffering from mental disorders. Is it a lot or not? In fact, quite many more people are suffering from mental conditions. Every 20th person suffering from depression, actually, and we can trust these numbers about the number of people who applied for psychiatric assistance. These are 3 persons, and most of them are adults who at the same time can acquire social services. Secondly, these are people without severe forms, people who are not requiring treatment in an inpatient clinic. Next slide, please. If we concentrate our attention on the most important diagnosis, then of course, more frequently than not, in long-term future, people with schizophrenia are well known to people from inpatient clinics, and in the list of participants today, I saw a lot of psychoneurotic institutions. If we look at them from their eyes, it would be mental retardation and schizophrenia. But most of the medical diagnosis, if we take 2017, the last available diagnosis of depressions was given 3 times more frequently than schizophrenia. So depressions indeed are a more significant social problem. And again, in the context of the elderly, in the context of the situation with the COVID-19 pandemic as part of the social isolation, can have a huge stressful impact on people, and they can also consequences of the coronavirus infection itself. And here you can see the suicide parameters. Belarus has emerged from the high-level countries in terms of the WHO level. High level is more than 20, and most recent available year, 2019, it was under 20. For 2 years in a row, it was below 20. Doesn't mean that the relevance of this problem is going down. No, Belarus continues to be in the group of countries, out of at least former Soviet Union countries, where the problem of suicide is still relevant. But still, this reduction means that all the efforts undertaken not only by the psychiatric or mental health, but also education, health sector, and the prevention sector are delivering good, tangible results, and the work on the mental health can really save people's lives. And one of the ideas of my presentation here is that if we pay more attention to mental health in any age whenever people apply for it, is something that can save them from suicide. It is impossible to deny a person assistance, because potentially if a person is denied such assistance, they can become a victim of suicide. But service provision can drastically reduce the risk of suicide for a person with any mental health conditions, be it depression or other disorders. Next slide, please. Here, I would like to draw your attention to our neighbor, the Russian Federation. The situation in Belarus is not unique, and the problem of suicides in Belarus is tightly combined with the numbers in the Russian Federation. Additionally, please pay attention to yet another thing, which is less related to mental health, but one way or another, this is the sector that people are talking about. This is consumption of alcohol. And many receivers of social services have their relatives, mostly young adults, who cannot be registered as caretakers for their parents because they're dependent on alcohol, but nobody prevents these people to have access to their pension and create a situation of mental dysfunctionality when this adult person can become a victim of domestic violence. So these two contexts, context of suicide, the context of alcohol abuse, always come hand in hand, because a lot of people, 40% of people who committed suicide were drunk at the moment of committing it. Next slide, please. Here, I would like to tell you more about how we address this mental health problems, how it is done by different services in our country. I specifically abandon using the word of psychiatric assistance, although our law is called just like this, but in real terms, people with mental illnesses and conditions, there are many more people who work with such people. At least in all small district hospitals, most of the people there are not people from Minsk, but rather people from local social centers and institutions who are located in rural areas. They employ doctors who do not have the first part psycho. They're neurologists and medical nurses. And in fact, for quite a while, for a year and a half, it is the outpatient medical assistance, which is the first front and center for mental health system. I will tell you more about this. I will explain where nurses and doctors can be used here. It is also social worker who can apply to them, and territorial at the lowest level, we have a service of mental health. Everyone from the social centers knows their district narcologists and psychotherapists and psychologists, and this is the front-end row who provide assistance to a total of 80% of population from Belarus, because 20% live in Minsk. Social services provide assistance not only via psychologists. When we recalled them, we recalled psychologists. First of all, it sounds like it is psychologists who should work with mental patients, but actually psychosocial assistance can be provided by social workers equally well, and social workers without any psychiatric or psychological education. Next group of assistance is helping not only children. Specialists from the education system help also adults, because when we come back to the social centers, these are parents who often have problems not only with alcohol but also mental health issues, and the consultations and family support, not only psychological but also educational, is one of the components of psychological mental health. Next slide, please. Here I would like to tell you more about the structure of the psychiatric service of the healthcare system. Again, this statistical book of 2017 that I quoted from previously, it contains information about hospitals, and there are a lot of people from hospitals who continue to be registered in mental hospitals. We have some of them in regions, and there is a stationary, there is an inpatient assistance, and there is a huge national mental hospital which is located now on the territory of Minsk. And according to the most recent data, about 3,300 psychiatric beds are there. There are a lot of outpatient clinics. In Minsk, for instance, there are 2 outpatient clinics for adults and young children. And also they have some inter-district dispensary clinics. Also in large towns, Baranovich, Bobrusk, Borisov, in almost every large district they have such outpatient clinics with a certain number of beds for mental patients, in Gomel region as well. And we have quite a number of mental health wards in our hospitals, also in outpatient clinics. And when we look at these numbers, you might be surprised that the number of therapists now quite big. There are more than psychiatrists of them. That is indeed true. This assistance is becoming more accessible. Next slide, please. Now it's going to show information with this number of psychologists in the healthcare system. If we look at their positions, and this is the last line, about 500 people, and they're not only psychologists from outpatient clinic, they're also psychologists from inpatient clinics, the specialized palliative assistance service. And if we understand that these 500 psychologists covering the whole adult population, which does not work with the psychosocial service from our system of education, and which does not include our social service agency, then it turns out that these 500 people, for conditionally speaking 7 million of adult population who are in an able age, who are not children and not pensioners yet, this is by far not enough. And let's hope that the number of psychologists in the healthcare system will increase. Next slide, please. And here, naturally, there are all sorts of other structures and services. Now we're developing outpatient services. I'm going to say that all the inpatient clinics are covered by the budget funds. All the medications and drugs are provided free of charge for mental patients. I spoke about outpatient clinics already, and I still believe that this sector of mental health is covered by our special social service center, and also schools and educational institutions also provide such services to children with mental conditions like or with autism. Next slide shows it was the previous slide. Next slide, please. Yes, thank you. So this is the system of non-governmental system, but rather closely cooperating with the governmental system. Now, of huge importance and popularity are the psychologists and consultants. They're often called therapists, but they do not work as general practitioners, but they're specializing on a certain type of therapy. And there are quite a number of psychologists in these private centers, and it can be compared and comparable to the number of psychologists in the educational sector. So these are private institutions, private service centers, pensioners. They healthcare centers, they accept patients with dementia and mental conditions. Once again, I would like to thank our NGOs who decide to come and work in this field, but it's not only NGOs, it's also religious organizations and self-assistance groups and clubhouses and their system who are supported by NGOs. I hope that soon it will become a separate service, because it's quite clear that clubhouses are something that can, in our Belarusian situation, turn into a service system through the state contract, or when a state seeing the assistance or a contribution of the service can decide to continue the supporting it by funding them somehow. Next slide, please. Why did I want to tell you about this? Because for the first time ever since 2020, the theme of mental health and protection of mental health is viewed in the context of our global program of health and demographic security, the first state program on protection of mental health. Before that, we had programs on prevention of alcoholism. Then we worked with also TB and non-infectious diseases and HIV/AIDS. But since last year, we started to develop this program, and it's become functional ever since this year. What is this program about, and how it can be useful for our subject matter of discussion? Next slide, please. This is the program which says that the protection of mental health is a priority for the state, and the reduction of number of suicides is viewed as one of the components of ensuring this mental health for our people. Among the resources and the directions of these activities which are planned for it is the strengthening of the primary line of assistance, because it is as close to people as possible. This is prevention of suicidal behavior through medical and psychological assistance, social assistance and support and resocialization capacities of opportunities to return them back to the functionalities available to them before the onset of disease, and assistance to children in the crisis situations, which is important for longer-term work as well. Next slide, please. This program is talking about the special role played by the general practitioner, the therapist, and of course we're starting by saying that now we're training our doctors with the support from WHO. We have organized a program of training to detect based on major gap. It's not only about depressive anxiety disorders, but something, the bereavement reaction after the death of a relative. This is not necessarily considered within suicidal behaviors, but also within this COVID-19 pandemic, which can be hazardous to people's health, or survivors of domestic violence. Next slide, please. What about the education system? This manual contains a number of modules. I showed the module about dementia. It was written specifically not for psychiatrists. And of course, aside from medical knowledge or special medical information, this guideline or manual contains quite useful things about the description of what dementia is, what is the behavioral symptoms that can characterize it. This manual can be used also for the training of not only general practitioners, but other specialists in the context of mental health. Next slide, please. And owing to the fact that general practitioners ever since last year can now prescribe medications and treat depressions, there was a clinical protocol prepared one according to which now a person living in a district who goes to the local district hospital, or they have an outpatient station of, they don't need to go to the bigger hospital for psychiatrists. They can apply to the local doctor about their depression concerns. So the services has become closer now. Now tens of thousands of doctors, of general practitioners, this is the most frequent specialization in terms of the number of specialists in the mental health, has become much closer to people. What we're doing now, we continue to train these people in this basic knowledge, which has been developed by the international organizations such as World Health Organization through methodological letters and trainings. We do it continuously. Next slide, please. Thank you. I've been saying before that the system of providing assistance to people with mental illnesses or mental health concern is not only a concern of psychiatry. Here we need to mobilize our communities, no matter how many psychologists we have. Of course, I'm dreaming about 1,000 psychologists in the healthcare system, but we do realize that the healthcare system, even over the most wealthy country, we are still capable of supporting our public system quite well. Still, we won't be able to provide full coverage for all people. Still, people will be coming to social service organizations, to NGOs, and if communities do not decide to create services who will provide full coverage for such people, the consequence of non-provision of such assistance can be not only suicides, but other crisis situations. Next slide, please. What services can be important and useful? Returning back to who we have here, rural areas, small towns. Of course, it would be great if we had not new people there, but rather those people who we already have them get new knowledge. Now we are visiting different regions, working with general practitioners. Equally important would be for people from social workers and social centers, and those social workers working on the forefront. It would be great if we were included into the retraining courses for social workers. Some of the elements of mental health were included into the Minsk district cycle of seminars, when we spoke about the prevention of suicides, but that's what we do with the trained specialists. It's important to pay more attention to the society, and the stigmatization is one of the barriers when people do not go neither to psychiatrists nor psychologists. They never apply to mental health services, and here we need to educate our people the way we educate them in the context of COVID-19 pandemic and vaccination. We also need to educate people who make decisions at different levels. We have managers from the departments of labor and social protection working in the district executive committee. We have chief doctors working with the deputy heads of executive committees who have delivered to them a message about the importance of this, because we're talking about 5% of people. This is every 20th person in Belarus experiencing depression. And in context with local media, quite recently, owing to the cooperation with our Association of Social Workers, I was interviewed. I once again spoke that the theme of mental health is not sensation subject. It is, we shouldn't be telling about what happened where, but rather where people could apply for assistance. And the next slide I specifically included in my presentation in terms of stigmatization, because often people have an image about people with mental illness. People are suffering from mental panic when they think that people with mental condition will take up a bus saw and a chainsaw and kill their care providers or doctors. But we'll repeat once again, 70-80% of people with mental conditions, people are totally harmless and do not require any treatment in an inpatient clinic. And this moral panic, which is created from the sensationary side of the media coverage, which makes us our work difficult. And the last slide, if I may. What else can I say? I said that the financial costs of a family are at a maximum now, and of course, the public support is important here, but the community support when there is a family who have already received some assistance, but still they do not cope completely. And the social forms of rehabilitation when one family is not a more wealthy family, but rather with better solidarity can help other families, or a few families help another family. These are the forms of assistance that we can develop, considering that most of the people do not live in Minsk, to maximize access to such services at the place of residence. Or if a person goes to the region, such assistance can be provided not only at the place of residence of Stolpci, Karelichi, and say Pinsk district of Belarus. As long as we have decided to reduce the level of services down to the ground, in many countries, like creation of mental health centers, perhaps, but not necessarily, it can be done at the district level, when specialists and consultants can join it, not only with psychiatric education, but can be accessible also for social workers. Many district centers, like in our neighboring countries, social workers are playing an important role. Also online consultation is possible, but only in those places where internet is accessible. But we understand that in rural areas, elderly people do not always use internet, and under these conditions we can think about psychiatric in-house support. This is a very promising assistance used in the world when a person is not institutionalized, when he stays at home, but he's actively visited by specialists, and to the extent that it is possible for general practitioners, it's not psychiatrists, but general practitioners who are visiting this such person, and sometimes a trained psychiatrist can visit them as part of a team, and it's not like an emergency team taking a person and institutionalizing them. It's just a team made up of a psychiatrist and a nurse who can consult this person in house and who keeps living at home, and they're keeping in touch, and to prevent placing this person in the institution or mental hospitals. This is what I wanted to tell you about today. Once again, I would like to thank the organization that invited me here, and I've shared many links to the resources that we have. If you want to, please approach us. Next slide, please. Sorry, this is about a somewhat different subject. These are our phone numbers that you can refer your patients to. We have round-the-clock 24/7 hotline, independent of their place of residence. We use social network messengers, Telegram, Viber, WhatsApp. Without phone number identification, you can also get consultation by filling in a special form. Thank you once again for the invitation to participate in this event. Thank you. Thank you very much. Alexei Alexandrov for the invitation to cooperation. Thank you for your contribution and the support. I would like to give the floor now to our colleague from the EU, who I'm talking about Mr. John Saunders, who will tell us about the experience of his federation, who are supporting community-based organizations in different countries and families affected with mental illness. Over to you now. Colleagues, once again, now I'm giving the floor to, yes, there were some technical difficulties for the translation. I'm giving the floor now to our colleague from the European Federation of Association of Families with experience of mental health, who is going to tell us about the strengthening the capacity and advancing of the interests of families of people with mental illness.
Good afternoon, everybody. And it's a pleasure to be with you. And thank you very much for the invitation to join you today. I've listened to many of the presentations this morning and have learned much about how services are being developed in Belarus. My role is, I suppose, to talk a little bit about what's been happening in the continent of Europe through EUFAMI. And first of all, to say, if you move on to slide next, please. Slide number 2. EUFAMI is a European-wide organization, and we represent family organizations in many countries across Europe, as you can see, from west to east. And these are organizations that are primarily supporting family members where there's a person with a mental health issue. And sometimes we have organizations which do support not only family members, but also support people with a diagnosis. So it's very much a mix. But our mission, as you can see, is to represent all family members at European level and to protect their rights and interests and to promote those rights and interests. So next slide, please. The subject of today is around community care, and for EUFAMI and through many of its member organizations, we believe that community care often means family care. In other words, when people are not in hospital or in specialist residential services, they are usually living with some family member, and that family member is providing much of the care that is required for the individual. We also believe very much that the causes of poor mental health and mental illnesses and the prevention and the interventions have to be biological, which obviously means medical intervention with perhaps the use of medication, psychological, the use of talking therapies, social and economic, social support schemes, education, training, and economic monetary support if required by the national government or national mental health care service. We also believe very much that the quality of recovery is positively influenced by appropriate family care. And we do know that in many parts of Europe, there has been research carried out which suggests that the quality of recovery that people make with mental health areas is directly related to the quality of appropriate family care. In other words, if there's a very strong supportive family, and usually we talk about 1 or 2 carers being the main influence, then that person's recovery and his quality of life is likely to be more positive. So for us, from the point of view of mental health, it's not just a psychiatric problem, It's not just a medical problem, it's not a social problem, it's not just a psychological problem. It is in fact a problem for the whole community. And in that sense, we say that mental health is a political issue and everybody should be involved in providing a solution, from government, the civil service, NGOs, professional organizations, and professional services, obviously. So, next slide. Next slide. Thank you. So from the perspective of families, we believe and we know that often mental health services need to get good, accurate information about the individual that they're dealing with. And sometimes that information is not readily available to the individual for all sorts of reasons. And very often family members will have information that can be very useful to the recovery process. So they can share information, for example, about lifestyle, about habits that person has, about triggers which might cause the onset of a crisis, and so on. So they can provide a much fuller picture of what's happening with the individual beyond that information that might be available through the patient himself. The second thing we do know is that when a crisis occurs, often the family member or members are the first people to deal with that crisis. In some countries, there is very, very good crisis intervention teams who can step in to provide support almost immediately. In other countries, unfortunately, those crisis teams don't exist, and therefore there might be some time, days or weeks, before a mental health service is able to respond to people who are in crisis. And this, I think, is hugely problematic for not only the family member, but for the person himself or herself, because he or she is not getting the type of intervention she requires at the time. The third area of family perspectives is that family members need support, information and training. And I've heard a lot about that today in some of the presentations. And we believe that there is a right for families to be educated and trained and supported by the mental health service to make sure that people who are mentally unwell are looked after in their own community, which I think is what everybody wants ultimately. So next slide, please. I think, and we've heard a lot about recovery today, and of course, your family fully supports the idea of recovery, really, really important. But we do know that involved families must be part of the recovery process. So I think our plea, our message to any country which is trying to develop good community-based mental health services is that families need to be involved from the start in the process to allow good recovery to happen. What does that mean? Sometimes it means something as fundamental as good quality and continuous communication. One of the complaints we often hear from family members, and indeed from mental health services, is that there's very little communication between those people. And what we're saying is that a mental health service should reach out and welcome in family members where appropriate to discuss and deal with issues in regarding someone's very severe mental health. Likewise, families should not be afraid to speak to mental health services and to share their concerns, and as I said earlier, share the information that they will require. Next slide. Again, from our perspective, we look at mental health services having the following characteristics. They must be what we call effective. What we mean by effective is that they do what they say they do. Often mental health services will say they do something, but when you look at it closely, you realize that that is not actually happening. For example, in many parts of Europe, Some services might say we provide a 24-hour, 7-day-a-week service, but then many of the services close after ordinary office hours. And really, we know that the crises that people have often happen in the evening time, at night time, or at weekends. And when you look to see if there's a mental health service available, you find out it will not be there until tomorrow or next Monday, or so on and so forth. So effectiveness for us is saying, if you say you do something, then you must do it. Efficient, obviously, is about making the best use of resources. And again, different countries have different levels of resources according to their ability to provide. But what we say is that those resources must be used efficiently to make sure that people get the maximum possible result from the service that are available to them. Timely is very important to us. Services must be available at the time needed. Again, we know in many parts of Europe there are, for example, early intervention services in psychosis being developed. This means that at the earliest possible onset of a condition, the person is receiving intervention and support from the service. And this, of course, means that they will make better recovery in the long run. Very often services you have to wait for services. And I think that's a really important issue to deal with in every country. Some countries have quite long waiting lists for people looking for mental health care services. So we need to make sure that the service is available at the time that's needed for somebody. Localized obviously means that the service is available locally in your own
Означает,
community.
что все должно быть доступно рядом, там, где человек живет. Очень часто в прошлом людям приходилось очень далеко ехать, чтобы получить соответствующие услуги и помощь. Но сейчас хотелось бы, чтобы люди могли получить это рядом, в своем городке, в населенном пункте, чтобы им не пришлось далеко ехать. Вкратце, мы предлагаем, чтобы все услуги предоставлялись правильным человеком, правильное время и в правильном месте. Это главный наш месседж. Следующий слайд, пожалуйста. Вкратце расскажу о руководстве,
which were launched earlier this year. And they are based on promoting a person-centered and rights-based approach to mental health services. So what they're saying, and your family very much supports this, that many people with mental health conditions and psychosocial disabilities face poor quality care and violations of their human rights. And this demands profound changes in mental health systems and service delivery. So in many parts of Europe, there are different laws about how people are treated, laws around compulsory detention or compulsory treatment, and they vary widely from some very, very good supportive frameworks to ones that are less than adequate in terms of human rights. In many parts of the world, examples exist of very good practices, community-based mental health services that are person-centered, recovery-orientated, and adhere to human rights standards. And I think people working in the area of mental health who have looked at other services will realize that there's huge variation between very, very good services and not so good services. And of course, UFAMI, as a Europe-wide organization, wants to promote and encourage high standards in terms of mental health care services. In many cases, the good practices that we're talking about in community-based mental health services show lower costs of service provision than comparable mainstream services. So I think we need to realize that it's not more expensive to provide community-based services. It's either the same or in many, many cases lower. And sometimes with good organization, good structures, good staffing, of course, you can provide a much better service at a community level than you might do at a centralized institutional level. Next slide, please. So the WHO guidance makes a very strong point that significant changes in the social sector are required to support access to education, employment, housing, and social benefits for people with mental health conditions and psychosocial disabilities. So this brings us back to the point that I made a little bit earlier about EUFAMI, that mental health is not just about health, it's about education and knowledge, understanding what's happening with you. It's about appropriate employment or activity for persons. It's about good housing, and it's about having good social benefits so that people can lead a reasonable quality of life and be able to help in their own recovery and support, and have family members can support them in that recovery. Next slide, please. So I just want to leave you with this link here. EUFAMI in the last year has completed a major piece of research on the value of caring. What we did is asked questions of family members about their own lifestyle and their own role in providing care. And we found some quite useful statistics, for example, about the number of hours per week that family carers provide care. And on average in the report, it was around 43 hours per week providing care for somebody. Of course, that care is not compensated in many places. Some countries have social systems which allow carers to receive an allowance. Others do not have that type of system. So the Value of Caring report gives a very good picture of the situation that many family members find themselves across Europe. So I would urge any of you to look up that. It's on our EUFAMI website, which is www.eufami.org. So next slide, please. So I'll leave you with just to say that listening to you this morning, to your very good speakers, I'm very encouraged that Belarus is certainly making steps to move towards community-based care. That's very much in line with what EUFAMI would want to see happening. And as a representative of EUFAMI, I want to say to any organization in Belarus, and indeed particularly to any family organizations, that we are more than willing to help and support any development that you want to undertake to improve the lives of people with mental health illnesses in Belarus, but also the family members and their carers. So thank you very much for the opportunity to be with you today, and good luck with all of your work.
Thank you very much, Mr. Saunders, for joining us today, for sharing your experience. On my behalf, I would like to say that we have already been using the data of the research that you conducted. Unfortunately, in Belarus, this information is not collected. I mean, the problems that the family members face while providing care. So your research is very valuable for us. It became foundation for our programs. I hope that in the future, we'll be able to share the results of our work in this sphere. I urge my colleagues to read this research. It's a very detailed one. It covers the work of carers. It describes the problems that they face, because in many ways it will help you to organize similar work in Belarus.
Thank you.
But again, it's very important we understand this. Thank you very much for your presentation. Thank you. Right, moving to the practical part. I'd like to give floor to our colleagues, to our colleague, representatives of the Brest Clubhouse, the model that has has been mentioned a number of times today, Yuri Salnikov, will tell us about the practices used inside the clubhouses, how they helped draft a recovery plan for people who are members of those clubhouse in Brest. It's one of the regional cities in Belarus. Good evening, everyone. I need a couple of seconds to set up my presentation. As my colleagues already said today, the model of the recovery model has already become an integral part of our Belarusian approach. The deep personal client-oriented practices are used at almost all the levels. Of course, it doesn't mean that the medical model that was active before, it doesn't replace it, but it adds to it. Thanks to our colleagues from the LYUDMILA clubhouse that were busy translating the My Shared Pathway book. They provided us with information about it. We tried to implement it this year. I will tell you how it works at our end. So what is this resource book or recovery book, My Shared Pathway? It's a list of questions that could be discussed by a person with psychological disorders and then specialist. It is used to understand what is happening with the person. These are the questions that divided into 5 chapters. You can see the chapters on the slide. The first was general understanding. It's the chapter aimed at understanding the reasons that led to the psychological disorder. And it's important for the people who want to recover and to leave this all behind. But it's aimed at people who in the clubhouse, particularly if it's the first episode. In the near future, our colleagues from the LYUDMILA clubhouse will try to apply it in the clinics together with the psychologist and the working in the psychological wards. The second chapter is called Me and My Recovery. Here we deal with the personality of the people. We deal with their convictions and values. This is something we'll be based on recovery on. The third chapter is called My Health. It's about physical and psychological health. We have a lot of convictions and stereotypes. Before a person became sick, they all had a number of those. The fourth is called My Attitude. Who is living next to this person? Who's new around this person? The members of the clubhouse could be the community members that could help the person recover. Very often it deals with the internal deeper convictions of people about the person's place in the society. It takes a lot of resources and time, this very chapter. The last chapter is called My Security, My Safety. It's about being responsible for their health, how to detect the triggers, what to do. First, to cut down the number of recidives. And it makes people believe that if something like this happens, they'll be able to deal with that, so that people understand how to deal with that. We know that we'll be able to fight the recurrence or the setback. What is the advantage of such books? The advantage is obvious when people start get involved in conversations. According to the British colleagues, they recommend conversations. When a person formulates their thoughts for somebody, they are more clear-cut in doing that. but the self-study option is also available. Again, it's the possibilities to look at the past and the future, in the present. We asked people about the past, when we were the first hospitalized, recurrent hospitalization. Discuss it with the person. It's important to make the person responsible for their life so that they become the subject of their life. So we construct the questions in the sense that the person will feel that they are important and they are responsible for their life. Next, there is a possibility to change or adjust what has been written. This notion is very important. Being in a state that they write down something, and then they understand that they want to add something after a while. So, and this possibility is available. This way they can change what they have written before. The last specificity is the individual approach and the own tempo. It means that we don't insist that person come every week and fill in the forms. When they're in the mood of doing this, they're welcome. So the chapters are for us and given to us not to stuck to them to a T. They can miss some chapters and avoid something, let's say, omit something. It's very much about the responsibility I mentioned earlier. Okay, what do we have available today? We have applied it in 2 clubhouses. In the leader clubhouse, these forms have been filled in by 2 participants. And the same is true about the Brest clubhouse. It's great to see how people get involved in that and they discuss this with other people, with other members of that community. New people get interested and they join come to us and they want to fill in the forms. It's an individual approach, 1-hour sessions happening once a week if a person is ready. It wasn't done more often because this way there will be confusion. So once a week is fine. It was a conversation with a specialist, with a staff member. It's an ongoing process. It doesn't happen overnight. The recovery process, the concept of it is a process. It doesn't have a end result like in the treatment model has. Next is the active role of each participant. Talking about the procedure, I wanted to say that I'm not going to talk about the results that we have achieved thanks to the book. I would rather talk about the positive sides that I've seen while my colleagues were applying this. What were the difficulties we encountered? And I'll give you some recommendations if any of you would like to use it. Next, what are the positive sides? The growing role of the person. When we talk with a person who has been socially isolated for a long time, they feel that they are not alone. There's not, but particularly not existentially alone. They're not alone in the group of people. And here, we're all do it from the heart. And when you do it with the people, they understand that they can change something. Next is a systemic approach to the data that we receive and to the data we provide. Since it's made in chapters, it helps people to construct the picture of their life. We all have this picture of life, and this book helps put everything in its place. The absence of the rigid framework, and limitations. The person already mentioned that when I spoke about the individual tempo. The possibility of reevaluating other people's convictions. It's important to be able to adjust, to rewrite what they wrote. So they think that maybe, the next point is the possibility of reviewing their plans and planning new things, set new goals and targets. Happens very often when inside we have a picture. It'd be great when I start doing this and that, doing push-ups and so on. When I wake up in the morning and I want to sleep and I don't want to do any push-ups or sit-ups, I better eat a piece of cake. So we're not saying that, telling the person that they've been bad. It's just their own choice, their own right. If they decide not to take up dancing instead of English, it's up to them. They're sharing their road with us. There are some difficulties, of course, they do arise. One of the difficulties is that the big breaks between the conversations, between sessions. We're talking about here about people who have some psychological or mental disorders. They could end up in the psychiatric hospital at some point. They may not have internal force and resources to have a session with a next specialist. Switching from external motives to the internal ones is the next difficulty, where often it's very difficult to work with a person who has been for a long time in the paternalistic model, when he was told that they cannot take care of themselves and they need care and treatment. It's very difficult to make people believe that they can do it on their own. Doing it with a book is even more difficult. Next point is the implementation of the plan on their own, independence in that. We're not, we're not taking the person by the hand and taking them to the recovery. Just we are witnessing the recovery. Independence in this respect depends on the paternalistic model that the person had been inside for a while. So we shouldn't expect that person to become independent from the very start. Next thing we cannot influence much is the integration of the clubhouse model into the bigger structures in Belarus and in post-Soviet space. Very often, many services treat people with mental disorders as mentally incapacitated. But you probably heard a colleague of us saying today that many people, they don't need to get hospitalized. They are not disabled. But the old system persists and it says that these people cannot decide for themselves. But hopefully the clubhouses will spread out and the new model will appear. What can I recommend for the practices? For the practice, I'll tell you what I have been using. First and foremost, it's the minutes of the sessions. Why it's important? Because we have big breaks between the sessions and several people filling in the forms at the same time. We need to understand it's important to have the minutes. You need to take notes. Could be any format convenient to you. You need to write that down to remember the facts mentioned by the person. And before the next session, you could reread that and go back to that. Second is the additional psychotherapy and psychological consultancy. The majority of the people who have ended up in the hospital psychiatric ward, unfortunately, forget that they cannot turn to psychotherapists and psychologists. This supporting therapy is very important. This resource book can be filled in by any specialist, any member of the clubhouse, not necessarily a psychologist, but the person needs to know that they have this possibility to turn to a specialist to go on. Next point is the SMART goal setting. I was surprised to learn that the British colleagues also do this. The major message here is time limitation. When a person sets a goal that they want to implement their potential, and you need to ask them a question: when, where, and how. So this is the frames although there are no official frames, we're not saying that you need to come here in a month and report on your progress. So we are just trying to teach this smart technology to the person. When the person is limited in time, it motivates them. Right, the memos that are convenient for the user. I used to use the smart memos for that. The person for them needs to describe their plans, write down the memos. So the best approach they use for them is totally individual. It could be a smartphone, could be a notebook. It is important because the session minutes allows me to remember what was happening during the previous session, and the person will be able to go back to his memo and rethink what they have written. That was briefly what we have been working on and with. This technology and this approach is very interesting, and I suggest it could be applied at any level. If you're interested, please contact the Social Work Association on the Clubhouse network, and I'll be happy to answer your questions. I'll be happy to tell you in more detail how to better work using the recovery book and using the resource book. Very often we adjust the questions to better suit our realities. Recovery is a life process. Important to remember that. We'll leave the Q&A for later. Thank you very much, Yuri. Still, I have a question to ask you. Question from Zoom. Are there any limitations in terms of age? And any is it useful for treating working with autists? I didn't have any experience of working with autistic people. They don't visit our clubhouse. In terms of age restrictions, majority of almost basically all visitors are 18, older than 18. But it's important that the person does it individually, on their own. They need to understand the question and answer the question themselves. So I don't think it really will help small children. I started with teenagers. It should be fine. They trying to find answers to the questions anyway. I think it was suitable for older age, but never tried it with the dementia patients and those with the autistic difficulties because they don't come to us. Thank you very much, Yuri. Now I'll give floor to a person who can say how much visits to the clubhouse affect people. She's a member of the Minsk clubhouse. Ekaterina is Babosova. She's a member of the rehabilitation services for people with experience of mental illness. Minsk clubhouse Open Soul. She supports a group of people with depression. Thank you very much for inviting me. It's great to take part in this conference as a speaker because several years ago I thought there was no prospects for that. Unfortunately, when I was when I left the psychiatric ward, I was told that I need to take my meds, but I was not given information about the therapy groups or anything. Unfortunately, a year later, I had a recurrence, a setback. So I understood if I don't take any additional steps, then I could face with this once again. So apart from taking antidepressants, antidepressant drugs, I went online to understand where I could get assistance. I found the website of the clubhouse and I started visiting the support group for people with depression. Compared to the polyclinic and sessions with a psychotherapist and psychologist, that the attitude in the clubhouse were more open. People are equal. They treat you as equal. They treat you as a person with a potential who can do a lot and for whom rehabilitation is possible. My father also suffers from mental health disorder, so I started visiting another group for relatives of people who suffer from mental health issues. So I was a member of the two groups. It's another effective group of cooperation because when a person leaves the hospital, his relatives do not always know how to treat this person and how to detect the crisis. Here, the relatives can exchange their experience on that. You can get support from people, support others, and also I visited lectures in the clubhouse. There was a special training. Basically, I decided to receive additional psychological education about the behavioral therapy. Hopefully these skills will be used by me, but now I'm managing the depression group. As a former patient, I thought that people could also get paid service for that, but I offered my help, so Pavel agreed, and I'm glad that I provide some training exercises for the people. I can explain to people what is happening with them, about the symptoms. And if people are not happy with the psychotherapist or psychologist, I can guide them and provide them with more contacts. So I can definitely say that Clubhouse is a great model of rehabilitation, apart from antidepressants. So I know that depression is not a sentence. And I know that people like me can be happy in this life and go on living happy life. Thank you very much, Ekaterina, for sharing your experience with us. That is great that people share their experience. It allows to learn it firsthand, and it's great practice. I hope this spreads further in Belarus because it helps to fight the stigma attached to this, to people suffering from mental disorders. Unfortunately, people are not always ready to tell about their experience. Now I want to give floor to our colleagues from the United States. They'll be making their presentations together. Dr. Ralph Aquila, the assistant professor of psychiatry at the Weill Cornell School of Medicine, New York, and Dr. Cyrus Daniel Napolitano, co-director of the Clubhouse New York Coalition, to tell us how community can and should take part in the rehabilitation and providing help to the people suffering from mental diseases during their recovery phase. Dr. Aquila, please, the floor is yours.
Hello, everyone. I hope you can hear me.
Gotcha.
Да, мы вас слушаем.
Okay. So as you heard, my name is Ralph Aquila. I am a psychiatrist. I worked many years with Fountain House. I am going to be co-presenting and talking about integrated care along with my colleague, Cyrus Napolitano. Cyrus, do you want to say a few words about yourself? And then I guess
Sure.
we can get the slide deck up and get going.
Absolutely. Good afternoon, everybody. It's a pleasure to be here with all of you. Again, my name is Cyrus Napolitano. I've been a member of Fountain House for almost 13 years, and I'm currently co-director of the Clubhouse New York Coalition. So I'm working with 14 clubhouses here in this city to advance the cause of clubhouses and recovery for people with serious mental illness. So if someone could put up the slides, we can get into things because I know we're a few minutes behind in the schedule.
So as you heard, my name is Ralph Aquila. I am a psychiatrist. I worked many years with Fountain House. I am going to be co-presenting and talking about integrated care along with my colleague, Cyrus Napolitano. Cyrus, do you want to say a few words about yourself? And then I guess
Sure.
we can get the slide deck up and get going.
Absolutely. Good afternoon, everybody. It's a pleasure to be here with all of you. Again, my name is Cyrus Napolitano. I've been a member of Fountain House for almost 13 years, and I'm currently co-director of the Clubhouse New York Coalition. So I'm working with 14 clubhouses here in this city to advance the cause of clubhouses and recovery for people with serious mental illness. So if someone could put up the slides, we can get into things because I know we're a few minutes behind in the schedule. Does someone have the slides or do you need me to put them up? Just need a...
All right, there we go.
All right. So if we can move on to the next slide, that would be helpful, please. So one of the things that we always like to talk about is the unmet need, both at the global level and usually here in the US, but I'm sure that there's a lot of information on these upcoming slides that are relatable to what's happening in Belarus and Eastern Europe. So of course, there's this huge gap of a need that needs to be filled around the world, and it doesn't really seem to matter where you're at. One of the things that I've learned over the past few years is that in low to middle income countries, which is an area that I'm particularly interested in and that I'm working on currently, is that over 75% of people with any sort of mental disorder has no treatment options available to them. And according to the World Health Organization, out of the 200 plus countries around the world, about 30 of them have some resources available to people with serious mental illness or any form of mental illness. So I think that's always something that's important to hear. And for example, if you're talking about India with a population of 1.35 billion people, there are probably around 5,000 active psychiatrists. If you're looking at Kenya in Africa, out of a population of 48 million, you have 75 active psychiatrists. So of course, there are not enough professionals there to deal with the need. If we can move on to the next slide, please. Looks like we're having some issues with the, things seem to be getting a little scrambled there. But anyway, even here in the United States, you know, those of us living with schizophrenia, bipolar, or clinical major depression, oftentimes there are not enough resources available for the individual. And if you look at a place like the South Bronx here in New York City, which is the most underserved community in the entire country, we're trying to build a new clubhouse with residential building next door to it to kind of address these unmet needs. If you look at the issue of homelessness, which is certainly connected to serious mental illness here in New York City and in California, the problem is almost insurmountable. And again, we're looking at ways to connect with various services and organizations to bring people together so that those who are living on the street oftentimes have a diagnosis of bipolar or schizophrenia, that we can get them the services and supports they need. And I don't know, Ralph, if you want to speak a little bit about that.
Yeah, I would first of all, I would like to just jump in and really underscore, and you can't really see this, but the second box talks about the decreased life expectancy that we see with people with serious mental illness. And one of the things that's been very dear to my heart and that we were working on at Fountain House since the mid 90s, and a project now that I'm involved with as I've moved to Philadelphia and working with another large mental health agency, is the fact that people with serious mental illness die so much younger. And that there were a number of reasons for that. I think most of it, and we'll get back to this later, but I think it's important to underscore a number of times throughout this presentation. And one of the things that Clubhouse model, and in particular Fountain House, has been doing is really focusing on what we call the social determinants of health, and really trying to get people to improve access to primary care, for one thing, but also when we look at things like housing, right? Because if you're not living in quality housing, it's going to have a major impact on your health. If you don't have access to quality foods, it's going to have a major impact on your health. So and again, we're going to get back to this later, but I really want to underscore the fact of what many people nowadays call integrated care. I would say that the community, the Fountain House community, has been focusing on this, and is something that has been really helping its members with for many, many years. And I would go on to the next slide. You got a fragmented slide, Cyrus. Not only
I know we've got a fragmented slide for the fragmented system.
Right.
Okay, so I don't know if anybody else can see this or not, but again, the entire mental health system here in the US and around the world is severely broken. No matter who you talk to, there are very few areas around the world where there's success built into all of the services that are needed for people. And, you know, we're always fighting about stigma and the misperceptions that people have about those of us with a diagnosis. And I think this is really critical to what the work that Fountain House and other clubhouses are doing. Is it helps to reframe and reshape people's perceptions about people with schizophrenia and bipolar in particular. this is a population where doesn't matter where you're at, that is the most stigmatized, marginalized, and discriminated around the world, no matter where you go, because people think that you're incapable of holding down a job, that you are violent and dangerous, when really in reality, people with those diagnoses are more going to be victims of crime. So again, the clubhouse exists to really reshape people's perceptions so that when you go to somebody, for example, I met a group of people a couple of years ago, and one of the women in the group goes, what do people with serious mental illness want? So I threw it back at her and I said, well, what do you think? And she gave some sort of general pat answer that really didn't get it to the heart of what I really wanted her to understand. So she asked me what I thought people with serious mental illness want. I said the same thing as everybody else. We want relationships. We want to have a family and raise kids. We want to have a decent place to live. We want to have a good job where we can take care of ourselves and not rely on other people just to get through the day. We want to be able to go to school and get a degree so we can get that good job. So again, it's about shifting those perceptions. The other aspect of this, and I'd like Ralph to speak a little bit to this as well, is that recovery from serious mental illness is possible. And I know he's faced this challenge around, no matter where he goes to talk, where if somebody says, I have a patient with schizophrenia, they don't want to expend the energy of the time because they don't think that person can live a rich, rewarding life. I mean, Ralph, what is your experience with this?
Sure. I mean, I think that's something that's worldwide, the underestimation of an individual that has a diagnosis of schizophrenia. Now, we know that with the appropriate resources, people do get better. And my point always has been is that we don't have an X-ray, we don't have a blood test to confirm that, but based on a good clinical history and based on experience, we generally know when people aren't doing well. And I always say that medication is the starting point. It is by no means the whole piece. It's just the foundation. I think it's important. And we do have new meds, which are very good, that help people to move forward with their lives. And over the 30 years that I've been practicing, I have seen significant improvements in people where they're able to go back and get a degree, where they're able to go back and hold down a job, connect with family, to get all the things that Cyrus was so eloquently underscoring. And again, when I always ask people, what do they want? The answer always was the same basic three things all of us want: a nice place to live, something meaningful to do, and a network of friends and family. So I think the next slide that we want to touch on is recovery. And I think that was pretty clear. So if we could go to that slide, and Cyrus, if you could kind of talk to that.
Right. So, recovery is not only possible, but it's expected at the clubhouse. And how does this happen? Because it's a process, a self-directed process where people with a diagnosis of serious mental illness in particular, and I bring that up, I talk about schizophrenia and bipolar in particular, again, because they are the most marginalized and seen as the most difficult to treat and work with. However, in a community setting like a clubhouse, where you have all of these services and supports in place through an intentional community, that wellness and people taking care of their health through the opportunities provided for people to grow into something much, much more than they ever thought possible. And that the person is not identified by the illness. Recovery takes place because it's based on the individual strengths, talents, and abilities. And oftentimes that's revealed in the clubhouse setting, because you're not at, when I meet somebody at a clubhouse, I don't go, what is your diagnosis? What medication are you on? How many times have you been in the hospital? Are you feeling well today? Do you think you could actually do this? Can you help me? No, I want to know, who you are as a person. Let's sit down over a cup of coffee. Let's do things like maybe stuff some envelopes, which needs to get done because we're sending out a mailing of some sort. You engage the person as a human being and not as somebody who is sick or is untreatable or is less because they have a specific diagnosis. I could care less what your diagnosis is because I see you as an individual, as a person with worth and possibilities that I look at, and I want to treat you with the dignity and respect you deserve simply because you are another person. That's how we approach things at the clubhouse level. And again, recovery is possible and it is expected. If you come into the clubhouse on a regular basis, I can assure you that it may take some time for things to change in a positive direction, but it's going to happen. And if you fall, you have people there to help you get back up on your feet.
Could we get the next slide, the recovery? Yeah. Keep going. Next slide. Next slide. There we go.
Yeah.
So why don't you read this and then just maybe just, I think you touched on most points. But...
Yeah, I did go through all of this, but again, you know, recovery is a self-directed process through which individuals with histories of serious mental illness improve their health and wellness within their communities, developing opportunities and identities not limited by their illness.
Right. All right. Next slide. So this would be a number of other models, because even though we are firm believers in the clubhouse model, just so everyone knows, there are other models out there. You see a social skills training developed by Robert Lieberman back in the late 80s. You have cognitive behavioral therapy. Aaron Beck, by the way, who just passed away, was the progenitor of that particular model. Cognitive remediation, which is kind of a similar approach, slightly different. Social cognitive training and individual placement supports that were basically putting a voc rehab specialist attached to what was an assisted community treatment model that I think many of you are familiar with. So I would go on to the next slide.
So the clubhouse model, you've heard me and Ralph mention what that, you know, we talk about clubhouse, but what is it exactly? So 73 years ago, a group of men came out of Rockland State Hospital here in New York State. They came together, mutually supporting each other so they could find an affordable place to live and find work. And this became what we called WANA, We Are Not Alone. So again, you already see the seeds of Clubhouse developing, because it's not the individual trying to do everything on his own. It's with a group of people that you're working together to achieve common goals and objectives. The Clubhouse model has been replicated in over 34 countries around the world, 37 states here in the US, and serves approximately 100,000 people worldwide. Now, if you look at the global statistics, that's really a drop in the bucket when you're talking about 450 million people with some form of mental illness, or you're talking about the number of people with schizophrenia. I think it's about 20 million, and bipolar is about 45 million. So there's still a lot of work to do. However, we believe that the Clubhouse model is the most effective way to allow a person to grow and develop into a contributing member of society. The approach we take is comprehensive and holistic. So we have this intentional community that we build together to support each other in mutual endeavors. And we integrate psychiatry and primary care together so that we're looking at the person as a whole person and not as a fragmented piece that only we're going to deal with your depression today, or your anxiety, or if you are overweight, or you're smoking. And Ralph, I don't know if you want to talk a little bit more about that aspect of it.
Well, we touched on it. And again, I think it's important to repeat this numerous times, is that people with serious mental illness die much sooner than the general population. There are a number of reasons for that. In part, the medications that are taken. In part, there is a genetic component. There are some very good studies that show that even first-degree relatives of an individual with schizophrenia, bipolar, or even depression have a greater prevalence, for example, of diabetes, right? And then finally, there is poverty, right? The social determinants of health. The fact that so many people with serious mental illness are homeless or in substandard housing, that live in what we call a food desert, where they don't have access to fresh fruits and vegetables, where they don't have access to quality food, where they can't afford quality food. So one of the things I always like to cite is that, and I'm assuming you all will understand this, a pound of bacon, which is mostly fat, is far cheaper than a pound of good lean meat. So people that don't have much money are buying foods that are going to fill them, but are certainly not doing them well. And that's, again, part of what the clubhouse is there for. And at Fountain House, over the years, we've done many different initiatives, including having a store where members could come and buy either meals that were just easily ready to prepare, or actually the primary ingredients that we got from farmers markets or from the farm that is associated with Fountain House, about 100 kilometers from Fountain House. So a comprehensive look, and just again, involving everybody in our intentional community, as Cyrus underscored, to really help ourselves as colleagues to have a better quality of life. Next slide.
And yeah, go ahead to the next slide. Yeah, which is, we've already covered some of it. I just want to make a point about, psychosocial rehabilitation and about promoting recovery. And again, we're talking about the integration of both the physical and the behavioral care. And what's really important, I think, and critical to a lot of what happens at Fountain House and other clubhouses is that much of the new initiatives or programming comes directly through the members. So for example, we can talk about members saying, we, in our culinary unit, we're serving sodas and cookies and things like that. Can we take that out and replace it with something healthy? So, we have this huge focus on having a wellness cart that goes around Fountain House with snacks that are good for you, that are affordable, to kind of fill that little need. The whole issue of smoking in the clubhouse, over the past few years, we now have no smoking anywhere on the premises at all. If you want to smoke a cigarette, there's a group of people that meet down the block. But again, these are initiatives that came through the membership with the support of the senior staff and the board of directors. And, Ralph has already talked a bit about the social determinants of health, which again is really, really critical, particularly if you're looking at the World Health Organization and what they're trying to do with the Sustainable Development Goals and things like that. And I think we can move on to the next slide, which is really about the intentional therapeutic community. So we talk a lot about what we do at Fountain House and other clubhouses is intentional. Everything we do, we want to have a purpose and a reason for. It's not about make work just to do work. When you come into the clubhouse, we want you to have a beautiful environment where things can actually take place, because we're looking at reducing isolation and loneliness. So you come into the clubhouse, hey, go to the home and garden unit. We need help making flower arrangements or putting plants around the building to make it a beautiful setting for people. If you come to visit Fountain House, when you walk in the main door, you're in a very different setting than a clinical or hospital setting. It looks like somebody's fancy home. There's artwork all around the building, all done by members. There's a beautiful statue of a ballerina made out of brass or something like that. That's an amazing thing to behold. You have members and staff working together to achieve these goals of recovery, where everybody has a reason and a purpose for being part of the community. And I'll give a quick example. When I first came to Fountain House, my attendance was very on and off, on and off. So I received a call one day from Angela, who was my worker, my social practitioner, and she left a message. And immediately my thought goes, what did I do wrong? How did I screw up? That's the mentality a lot of us with a serious mental illness have, that we're screwing up in some way. So I called her and she says, no, I just need you to come in today because I have something I need you to help me with. So it's engaging members in the work order day to actually see things happen, where you have a reason, there's meaning, the need to be needed. The other aspect of the clubhouse, and I think this is another critical important, is if you look at the hierarchy, you have the executive director, program directors, senior staff, unit staff, and then the members. What we do is we take that top-down hierarchy, we squeeze it together, and we broaden the base of participation where members are involved in the day-to-day running of the clubhouse. And we use oftentimes consensus decision-making to make things happen. And you can go back to the smoking or the wellness initiatives or the Silver Project, which was a program we developed for people 55 and older. Ralph, do you have anything you want to add to that?
No, I would just underscore the consensus decision process, because that's another buzz phrase in mental health, and that's something that the clubhouse model has been doing for 70 years. The whole, I think, and that's an important point. Working together and shared decision making or consensus decision making is again, pretty much becoming accepted, at least in words, in the rest of the mental health world. But the clubhouse world has been actually living and practicing this for 70 years. So I would go on to the next slide.
Right.
So I think we've done a lot of this, Cyrus.
We can move on to the next one.
Next slide. So, I mean, I think just to say that we do have data, we do have research, we are actually involved, engaged now in getting more data and more research. But we do know that the model works. We do know that it does improve quality of life. Studies going way back to the beginnings in the 70s, reduced hospitalization, much better employment outcomes than other models. So we do have empirical data. We are considered best practice amongst the best practice guidelines for mental health, and the model is clearly an accepted and world recognized model. I don't know if you want to add anything here.
Yeah, recently the World Health Organization recognized officially on their website the clubhouse model as an accepted form of recovery and rehabilitation. So that's just something that, again, we're making great strides, but there's still a lot of work to be done. Can we go to the next slide, please? And this is talking about integration in a community system of care, which Ralph, if you want to start.
Sure. So we again, there's been so much discussion worldwide about integrated care, and that you see on the left side of this slide. So for many years, Fountain House, the leadership, the membership understood the importance of integrated care. So we have had primary care doctors embedded in our clinic setting. Currently, Fountain House is involved in a project where we are working with a federally qualified health center just down the block from Fountain House, where there is primary care and a number of other specialties. But that's only the beginning, okay? Because if you have diabetes, no matter how good the endocrinologist is or the doctor is in prescribing your insulin, you are not going to get better unless you have a good diet and you exercise. So again, at the clubhouse, we do numerous things around exercise, around engaging members to become more active physically, to look at what they're eating. We have assistance in shopping. We do education around healthy meals. But at the end of the day, what's also important are the other social determinants of health. And we mentioned isolation earlier in passing. And there is data out there that shows that isolation, loneliness kills. So what we try to do is to provide people with meaningful, not just socialization for the sake of socialization, but meaningful socialization. Employment, you think about wherever you go, what's the second question after people ask you, what's your name? What do you do, right? What do you do for a living? Because that defines you in many respects. Education, where would any of us be without our education? And Fountain House for many years now has been giving scholarships that are funded by a foundation called the Sidney R. Baird Jr. Foundation. And I just want to say, one of our beloved trustees and friend of Fountain House just passed away this past Saturday, but a man who clearly believed that there was no limit for Fountain House members to achieve and to be successful. And wellness, we've touched on that. Relationships. You know what, Cyrus, we didn't really talk about that much, but one of the things I'm trying to do here in this new place that I'm working at is underscore how relationships are the key. You kind of touched on that when we talked about your worker, but I think we really need to highlight how important relationships are, because in my clinical experience, had I not had the social practitioner that helped me develop that trust with the member wouldn't have really bought into what I was recommending, what I was suggesting. Because at the end of the day, we talk about all the social determinants of health, but we also understand the value of quality diagnosis, of quality of pharmacology, whether it be psychopharmacology or just general practice pharmacology. And all of those things require an understanding and a trust in the person that you are sitting in front of. And for me, it was always important that the member knew me as Ralph, not as Dr. Aquila. I know I'm a doctor. I don't need anybody to remind me of that. What I really needed was for that individual who has undergone so much trauma. And one of the other things that Fountain House was way ahead of its time was the notion of trauma-informed care or trauma-informed support, because we know that most people with serious mental illness meet the criteria for post-traumatic stress. And for me, it's post-traumatic stress until proven otherwise. So the notion of relationship is so key in our abilities to get people to move forward and to get better housing, to get more socializations, and to have an overall better quality of life. Cyrus.
Yeah, I'll touch on that as well. The whole relationship aspect is, it usually just starts off with the member and the staff. But over time, it really develops into a group of people that you're associated with, that you work with. I'm also part of the Center for Leadership and Education at Fountain House that does not just colleague training, but does some other specialized trainings for leadership and directors, the Raw Journal of Social Practice, all of the things that we do together. And this is a group of people that I will do anything for. They need help with something, I'll stick around and we'll work on that and get it done. If you need somebody to talk to at 3 o'clock in the morning, I'm certainly available. So the relationship aspect, again, is critical, I think, to everything else that happens. If you don't have the relationship, you're not going to be engaging people in the work order day and getting their goals and objectives met. You're not going to have the ability to do the assessment where a person is at. What do we need to work on together? So I think this is really important. Can we move on to the next slide, please? So, we talk about the implementation of social justice, and what do I mean as a member of Fountain House and a representative around the world? For me, it's about the basic human rights, the dignity of the individual, because they are human. They are like me in many ways. They have made a different perspective in things, or they have different abilities and skills and talents. but it's a commonality that we have where we get stuff done together. Just respecting somebody, hearing what they have to say on a particular issue, that what they have to say and what they do and contribute matters at the clubhouse in the community. And it's really this kind of vision of seeing people more. They're more than just the diagnosis. They're more than just the illness. There's somebody who can contribute to the clubhouse and to society at large. And it's really influential when a member can have an impact that's just not only on themselves. And an example I can give is that if there was a member, I don't remember her name off the top of my head, and we have Metro cards, which is how you ride the buses and subways here in New York City. And through this one particular member advocating at the city and state level, that we were able to get half fare Metro cards because it's so expensive to ride the subways and buses. So because a member took it upon herself to make sure that this happened with the support of the clubhouse community, those members who apply for a half fare Metro card can ride the subways and buses without worrying about, I can't go to my doctor appointment. I can't go to work because I don't have enough money to buy the Metro card. So it's these ways where you're engaging the member in really having an impact beyond the location of the clubhouse. And this is very inspirational. And this is something that motivates me, and I think it motivates Ralph as well, to really go above and beyond what you would normally do to really contribute and help people achieve what they never thought possible. So I don't know, Ralph, if you want to add to that.
I guess I would just add, Cyrus, that what exactly are we doing? Because we didn't really define it at the beginning. So Partners in Care is a multi-partner initiative that includes numerous members, as you would expect, to disseminate this notion of community system of care that we've touched upon through the clubhouse model. So basically, what we've done with an advisory board of luminaries from all over the world, we've come up with this slide deck, which you're seeing, which Cyrus and I now have presented a number of times. But we also have a curriculum, which we'd be more than happy to share with anyone who would like it. Our intent, from what I hope you've gathered from this presentation and the eloquence of Cyrus, at least, that there is hope, there is possibilities of recovery, and that we are suggesting that the clubhouse model can be a very cost-effective and efficient modality. So this Partners in Care, or PIC, as we call it, PIC, is something that we believe very strongly in, that can help individuals and societies and organizations around the world to really deliver state-of-the-art health and mental health care. And I guess we should go to the next slide.
Right, that's the patienthood to personhood. So you go from somebody who with a diagnosis to somebody who contributes to society. And I mentioned that member who got the half fare Metro card by doing public lobbying and advocating at the city and state level. But I'll just share a little bit about myself. Before I came to Fountain House, I was involved with a support group. I was a facilitator. We did groups for bipolar and unipolar and family and friends. And I became very, very sick. And I was in the hospital for weeks undergoing ECT treatment. Came out worse than when I went in, if you can imagine that. But a couple of friends of mine from that support group were able to get me into Fountain House. And it's really interesting to look back over the past almost 13 years to see my own personal growth and development. I never thought that I would be sitting here with you today, giving a talk on the clubhouse model and the importance of having a clubhouse in your community, where recovery is not only possible, but expected. I never thought that I would have the chance to make my own film and be involved in multimedia. I've done a bunch of writing. I do public speaking all around the world. I'm co-director of the Clubhouse Coalition here in New York. The ability to do these things happened because I was part of a community that supported me through my ups and downs. And this is not to say that I haven't had difficult periods of time. This April, I went through a very severe depression, and Ralph helped me through that, and I love him to death for that, because he was there for me, and I had other people there for me. So it's not a magical panacea that everything is going to be all hunky-dory and perfect, but you have people that care about you, that want you to succeed, that want you to have a life, and to do the things that you never dreamed of doing. So the opportunity to mentor people and help them grow and develop. My friend Judy, who recently passed away, she said, "Oh, I want to be just like you." And I said, "No, that's not what you want. We want you to be who you are meant to be." So we sat down over weeks and came up with a plan of, these are the areas that Judy wanted to focus on. And it was amazing to see Judy grow into this person that was so well loved and respected around the world, where she was able to do the things that she never thought possible, because she had the support of her friends and her family in this community that allowed her to grow and develop as an individual. So that's to me, that's the core essence of what we do. It's about mutual support. It's about love in many ways. And if you fall down, you have people to help you get back on your feet. So I don't know, Ralph, if you want to say anything in closing, because the next slide we don't really need to, I think, get into. It's about partners in care, but we can share that with folks offline.
No, I would say, as always, Cyrus, you were very eloquent and really clear on what we're about, what Fountain House is about. And I think remembering Judy, who I worked with for so many years, and just saw what an incredible tribute she was to the whole meaning of recovery and what's possible. She overcame so much adversity, and just was just such an inspiration for me. I was so inspired by her, and you, Cyrus, but so many other members over the years that I was their doctor. I was just so inspired, and just to think of the kind of, I've been very fortunate, very blessed. I've had some adversity, as I'm sure most of us in this audience, but to overcome the kind of adversity that so many members have done, I'm just always impressed, and just always touched, and just so thankful for having been part of Fountain House for all those years. So yeah, thank you all. Thank you.
Thank you.
Do we want to close, Cyrus, and go to?
No, I think we have a few minutes for questions, if anybody
No,
has.
I meant close slides. I meant done with our slides, right?
Yeah. The next slide, we don't have to go into.
Yeah, okay. So we can open it up.
Partners in care. But, it's been a real privilege and an honor to be with all of you here today. Every chance that I have to speak about Fountain House and the people I work with on a daily basis is, to me, life-changing. It's transformative. And again, the possibilities seemed to me so limited 13 years ago, and now it's like the whole world is open to me, that I'm looking and exploring as what are the next steps for me? I'm 60 years old. What do I want to do? Where do I want to put my energies? But I have a place that I can always come back to, and that's Fountain House on 47th Street. So if anybody has any questions or comments, I think we have a few minutes to do that.
Thank you very much, Dr. Aquila. Thank you, Dr. Aquila.
Welcome.
And thank you, Mr. Napolitano, for your joint presentation. It was very accessible and very comprehensive when you spoke about this community-based system and what role can be played by the community in the recovery of a person with mental condition history, the American model of the clubhouse, showing great results in other countries of the world, which has been working in Belarus for a while now. Thank you very much for today's participation. We don't have questions about your presentation. The only thing I can read out for you from the Territorial Center from Narovля, they're thanking everyone for the invitation to this briefing. Thank you for sharing the information. This information was very useful for all of us, and it's great that we have an opportunity to discuss mutually important issues owing to the internet platform. I'd like to thank the organizers of the conference, and today we're finally starting to facing people with disabilities and people with mental illnesses. Only jointly we can overcome this, and I would like to thank CYRUS Napolitano. You're a great example of limitless capabilities. And also we start receiving thank you words from territorial centers from other towns. Thank you, colleagues, for joining us. Thank you for joining us. And I would like to pass the floor for final remarks to Lyudmila Averkina, who is going to say a few concluding remarks for our today's event. Thank you very much for the great opportunity to thank all the participants and everyone here in this room. You know, in fact, I find it real pleasure because it is the first time when we brought together people from the medical field, from social working field, from community field. Everyone is concerned how to help our neighbors and our people. I was listening to one of the presentations here and liked very much the overriding message there that I'm a medical professional. For instance, I'm signing off this individual from my inpatient clinic, and how important it is when this person will finally be able to fit in life, when they will be able to get access to support and services. And it's not always medical support or social support. Such form as clubhouse model really inspired me. Today we had information about clubhouse operation. I would like to thank them for all these presentations, because people indeed start having a great opportunity to open up and see other people who have lived through the same difficult times. And here we don't need specialists, we need more of an open heart, and we need to create this community around people where people would feel themselves empathy of people around them, and get in time the assistance when they won't have to go to medical institutions, because our ultimate goal is to make sure that we don't go to specialists, but rather for us to find in a moment in our lives when we are having hard times, the possibility to re-energize ourselves, to charge our batteries. And when, of course, medical assistance is required, we can get this medical assistance, but one day or another we will still return to the situation, the social environment where we need to be able to fit with a good quality of life. All of us are the same here. And as I said, this stigma about dementia, stigma about mental health must be eradicated. Our people and children must know that people like this live among us, and this is not a situation when they need to be considered like outcasts. Our society must receive and accept them and support them. And in that regard, only then we will be able to be called a really friendly society for all ages. I would like to thank everyone who participated in this good cause. Okay, thank you very much, colleagues. See you next time. That will be the end of our event today. All the best to you, and be healthy.